Pankaj sir.
Yes, Dr.
Yes, Dr.
Rajan.
Rajan.
Sir, you are Dean also. Dean sir also.
Okay.
Okay.
That's echoing, sir.
And Dean
And
also,
Dean also, right?
Dean inside.
BMS
BMS Econ 2021
CMS 21 MC, organizing Dean, and also Dr. William Secretary.
Okay.
Patient. Pankaj sir. Hello. Okay.
Yes, Dr. Rajan.
Before there was echoing, sir. Now it's okay.
Now it's fine, no?
Yes. So Dean sir is now in and
Yes.
inaugurations. Now you have to put. So there is one BMS Econ organizing team. They also should be in this.
Yes.
We have to put them also in.
Yeah, already.
MC is here. Already is there. Very good.
Yeah, BMS Econ 2021 2.
Yes, sir. That is
Who are
correct.
also panelists now.
This two will be there always, constantly, every day, sir.
Okay.
BMS
Fine.
Econ 21 and that they have to now. Again, echo is coming.
Are there two people sitting in the same room?
But it's muted, sir. Whenever the video plays, then the echo is coming. When we play the video, sometimes we talk, no, sir. Sir, that lamp lighting and souvenir release and all you checked to know, sir?
Yes. Already checked now.
Okay. So, and sir, you have to put Dr. William Stringer also in.
Right
He's
now?
in the he is in the inauguration also. He's supposed to come in the inauguration also.
Yes.
William Stringer, no, yeah. And
So, shall I
Dr.
allow him
Suresh
right
Shamal-
now?
You can put in after 5 minutes, sir.
After 5 minutes.
you
Yeah.
can- yeah.
Right.
And Suresh Shamal, sir. You just check Suresh Shamal, sir.
No, Dr. Suresh is not here. Dr. Suresh is not here.
Okay.
Good morning. Sir, I'm audible.
Hello, good morning, ma'am.
So we are checking the audio, sir.
Okay, please check video also.
Yes, sir. My video is switched on now, sir. In the name BMSC Con 21 MC.
Yes, it is fine.
Yes.
Hello. Audible, madam?
Dr. Rajan, you are mute.
Sir, please, sir. Now, actually, sir, Lakshmi madam will be joining and our Suresh Amal sir, sir. If they join, then I think in time we can start. You can put William Stringer, Dr. William Stringer in, sir.
Okay.
Rajan, what time the chief guest joins?
In another 5 minutes, they'll join, sir. They already joined, sir. They're as a delegate now. I'm telling them to put inside now, sir, as a panelist.
Oh, that William Stringer.
Yes, sir. He's joined, sir. Sir has joined.
Oh, great.
Now he will become panelist now, sir.
I am making him panelist now.
Okay, sir. Thank you, sir.
Let this go. Fine.
Hello.
Am I audible, sir?
Madam.
Okay, sir. Thank you, sir.
Sir. When you connect the link, you again ask the password code.
Sir. Yes, sir. Yes, sir. Hello.
Yes, sir. Yes, sir.
Sir, Suresh Amar sir can join. Put him in the panelist, sir.
Okay, ji.
Am I all set?
Yes, sir. You are here, sir.
Okay, fine. Fine, doctor. Okay, good.
Dr. Rajan,
Sir.
whoever is in the attendee list, they need to make panelist right now or not?
Yes, sir.
Can you please
All
check?
are now, sir. I'll just check it, sir.
Yeah, please check.
Yeah.
Mr. Anand Kishore, Dr. Aparna Vasant, Dr. T.C.B. Mandela, Dr.
No.
M.
Sir. No. Whoever is in the panelist, I'm checking, sir.
Yeah.
All are here, sir. So.
Okay.
Our dean is there. Yeah. I think all are here as a
Okay.
panelist.
Also, Dr. Rajan, you can also upgrade people if you want. You can also upgrade. You're a co-host. You can also upgrade people at your own.
Is that need?
In
Okay,
case there's
sir.
some confusion, you can also try to upgrade, sir.
Okay.
Dr. Raj,
Present for the
Dr.
Yes, sir,
Raj,
please,
were you
sir.
able to see the video of mine?
So before I saw, sir, now I could not see, sir. Background I could see, sir.
The video stopped.
And now I can see your image, sir.
You can see what?
The profile, sir. Your profile picture, no, sir.
No, that's right. But I'm just trying to switch on the video. I mean, okay, let me.
Now, sir, now it's coming, sir. Yes, sir. It's coming, sir.
Now it is fine, sir.
Okay, fine. Thanks.
We are going to start the session in next 2 minutes.
Yes, I think all the panelists can open their video, no, sir. Shall we announce, sir? Pankaj,
Yes, sir. Yes.
Dr. Jyoti.
Yes, sir. Sir, am I audible?
Yeah, you are audible.
Yes, sir.
Dean, sir.
I will give a countdown of 5, right? And after that,
1 second, sir.
we
Dean,
can
sir.
start.
Yeah, Dean. Yes, sir. Yes, sir. Dean, sir.
Rajan.
Yes, sir.
Rajan.
You are the here, sir. Yes, sir. Can you open your video, sir? So
Yeah,
we
one
are
second,
going
one
for
second.
countdowns. Yes, sir. Yes, sir.
We are about to start in 5 seconds. 5, 4, 3, 2, 1, live.
A cheerful morning to one and all present here in this online platform. With the divine blessings of our founder chairman, Dr. Shanmugasundaram, and with the benevolent support from our Chancellor and Honorable Madam Chancellor, On behalf of the organizing team, BMS Econ 2021, I take the pleasure and privilege in welcoming you all for the second International E-Conference on exploring newer modalities in teaching, learning, and research in basic medical sciences during COVID era. Jointly organized by the preclinical departments along with the Center of Biomedical Research, Arubadeveedu Medical College and Hospital, a constituent college of Vinayaga Missions Research Foundation. Last year, we ventured into this e-conference with the theme Emerging Trends in Research, emphasize on basic medical sciences. It was the first international conference conducted virtually. Last year, we had 20 eminent national and international speakers, around 1,020 confirmed registrations, around 180 papers for oral and 44 papers for Young Research Scholar Awards. And this year too, we have 1,000 plus registrations, 150 plus papers for presentation. This second international e-conference will enlighten you on newer teaching, learning modalities to enable student-centered learning and will also enable you all to explore the opportunities of translational research in the field of basic medical sciences. Once again, with immense pleasure, I welcome this galaxy of distinguished dignitaries, speakers, chairpersons for the inauguration of this virtual conference. Like every other auspicious occasion, let us start this event with tribute to the Almighty. For this, we have with us Ms. Sri Lakshmi Nair, first year MBBS student. Over to you, Ms. Sri Lakshmi.
मैत्रीं भजता अखिलहृजेत्री मैत्रीं भजता अखिलहृजेत्री मैत्रीं भजता अखिलहृजेत्री आत्मवदेव परानपि पश्यता आत्मवदेव परानपि पश्यता युद्धं त्यजता स्पर्धां त्यजता युद्धं त्यजता स्पर्धां त्यजता त्यजत परेशाक्रमणाक्रमणम् त्यजत परेशाक्रमणाक्रमणम् मैत्रीं भजता अखिलहृजेत्री जननी पृथिवी कामदुगास्ते जननी पृथिवी कामदुगास्ते जनको देव सकल दयालु जनको देव सकल दयालु दाम्य दत्ता दयत्वं जनता दाम्य दत्ता दयत्वं जनता श्रेयोद्भूयात् सकल जनानां श्रेयोद्भूयात् सकल जनानां श्रेयोद्भूयात् सकल जनानां श्रेयोद्भूयात् सकल जनानां श्रेयोद्भूयात् सकल जनानां.
This is a benediction composed in Sanskrit by Paramacharya of Kanchi, and it was rendered at United Nations on the occasion of UN Day by none other than Bharat Ratna Srimati M.S. Subbalakshmi. This song tells us how we should all live our lives in the short span, to cultivate friendship and humanity which all conquer the hearts of everyone. Look upon others as similar to yourself. Renounce war, forsake unhealthy competition, forego unrightful aggression or acquiring by force. Mother Earth yields all that we require. May all people attain all goodness. Thank you, Ms. Sri Lakshmi, for your vocal fest as always. May I now request Dr. Lakshmi Jatia, Professor and Head, Department of Physiology, ABMC, and Organizing Chairperson of this conference to deliver the welcome address. Over to you, ma'am.
Thank you, Dr. Jyoti. Honorable Chancellor, Dr. A.S. Ganeshan, sir. Madam Chancellor, Dr. Anuradha Ganeshan. Mr. Suresh Samwell, Member, Board of Management. Distinguished Chief Guest, Dr. William Stringer. Dr. P.F. Katur, Dean. Dr. Mahalakshmi, Dean, Health Professions Education. Dr. Vishnu Bhatt, Director, Medical Research. Dr. Jaya Singh, Medical Superintendent. Dr. Rajan, Vice Principal and the Organizing Secretary. Dr. Annachalam, Vice Principal, Student Affairs. Speakers, chairpersons, delegates. Good morning and a very warm welcome. We at Arpade Vidu Medical College and Hospital are honored and delighted to host this international conference for the second consecutive year. It is my pleasure to welcome you all to the inaugural function of BMSECon 2021. The theme of this conference is exploring new modalities in teaching, learning, and research in basic medical sciences during COVID era. This conference is the result of collaborative and synergistic efforts of the Departments of Anatomy, Biochemistry, Physiology, and Center for Biomedical Research, Arpade Vidu Medical College and Hospital. BMSECon, resource faculty and students across the globe for a vibrant and intense exchange of ideas, knowledge, and experience on emerging trends in research, innovative teaching learning methods, that too from the comfort of their homes and cities. Just like last year, even this year, we had an overwhelming response with 1,000 registrations and 150 plus abstracts for Young Research Scholar Awards and oral presentations. So on this joyous occasion, we are honored to have our Honorable Chancellor, Dr. A.S. Ganeshan, sir, who has been constantly supporting us in all our endeavors. I extend a very warm welcome to you, sir, on behalf of the organizing committee. Though sir could not join this inaugural function because of his engagement. And we are also delighted in welcoming our Honorable Madam Chancellor, Dr. Anuradha Ganeshan, who has been always guiding us, and we are always cherishing her guidance all the way. We warmly welcome you, ma'am, on this occasion. The organizing team also takes pride in welcoming Mr. Suresh Samwell, Member, Board of Management, VMRF. He is a man of unabatable energy, aspiration, and boundless ambition. Welcome, sir. The organizing committee is extremely delighted to welcome Dr. William Stringer, Chief Guest for today's inaugural program. He is a dedicated and passionate physician and researcher working at University of California and Los Angeles. We extend a warm welcome to you, sir. We cordially welcome our Dean, Dr. P.F. Katur, highly enthusiastic, perfectionist, inspiring, and a man of principles. Welcome, sir. We also welcome who had been overseeing all the arrangements. Welcome, sir. I also welcome all the honor guests present here today. Dr. Mahalakshmi, Dean HP, Dr. Jaya Singh, Medical Superintendent, Dr. Vishnu Bhatt, Director Medical Research, Deans of other medical colleges under BMRF, University officials, members of STD, faculty members of Arpade Vidu Medical College, and friends from press and media on this auspicious occasion. We welcome delegates who are joining us from far and wide. Without your support and encouragement, this conference would not have been possible. We sincerely hope you will enjoy today and the next 2 days of deliberations and networking. I once again welcome you all, especially our Honorable Chancellor, Madam Chancellor, Dr. William Stringer, Mr. Suresh Samvil, Dr. Couture, and all the delegates to this inaugural ceremony of BMS Econ 2021. Thank you. Welcome once again. Welcome all. Thank you.
Thank you, ma'am. I now request Dr. Ravi Kumar, Organizing Joint Secretary, to elaborate on the theme of the conference. Over to you, sir.
Thank you, Dr. Jyoti. Respected Chancellor, Chancellor Madam, today Chief Guest Dr. William Stringer, Mr. Suresh Samvil sir, our Dean, Dr. P.F. Couture, Director Medical Research, Dr. Vishnu Bhatt, our Dean HP Madam, Medical Superintendent, and all HODs and all our delegates. Good morning to one and all. In the face of the current COVID pandemic, the most of the events in the teaching, learning, and to some extent to research also have closed their physical doors and opened the virtual mode. As a result, the faculties and the students adopted an online teaching learning methodology at a rapid pace. In these circumstances, the universities and colleges are redrafting their curriculum to make them more flexible with online-based system, along with maintaining the standards without compromising the students' career. To explore the newer approach, techniques, and methods, we, the health professionals, should be aware of the latest advancement. So our organizing team has framed the needy theme entitled Exploring a Newer Modalities in Teaching, Learning, and Research in Basic Medical Science during COVID era. This conference can serve as a wonderful platform for all educationists and researchers to share their experiences and findings, which would be a great help for many other participants to improvise and put into the practice the novel and innovative ideas. So this is a unique feature of the conference is we have 14 scientific talks, 17 paper presentation sessions, which help us to share the research experiences by all our faculties and students. We also have providing a 4 Young Research Scholar Award during this conference. Once again, we welcome all our delegates who shows enormous support to our second International E-Conference. Thank you. Over to Dr. Jyoti.
Thank you, sir. It was a very crisp summary of our conference. The next event is lamp lighting. Lamp or diya symbolizes goodness and purity, and lighting denotes dispelling darkness and negativity. It's customary to start any event with a lamp lighting ceremony. Now, let us have a virtual lamp lighting by our dignitaries.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Deepajyotir parabrahma. Deepajyotir janardanah. Deepajyotir parabrahma. Deepajyotir janardanah. Deepo hartu me papam. Sandhya deepa namostute.
Thank you all. Dr. A.S. Ganesan, sir, our Honorable Chancellor, BMRF, couldn't make it to attend this event in person, and sir has sent his message. For this, I earnestly request Mr. Suresh Samvil, Member, Board of Management, to deliver Chancellor sir's address on Chancellor sir's behalf. Over to you, sir.
Thank you, Dr. Jyoti. Honorable Chancellor, Dr. A.S. Ganesan, Honorable Director VMRF, Dr. Anuradha Ganesan, Chief Guest, Dr. William Stringer, Dean, Faculty of ABMC Puducherry, participants across the globe at online, dear faculty members, and my dear students. A very good morning, good afternoon, good evening to all of you at whichever part of the world you are participating in this conference. It's my pleasure to join this conference virtually and also on behalf of the management to deliver a few words. COVID had brought unseen challenges upon mankind, nearly all aspects of our life, including our relationship to healthcare. The biggest hurdle being understanding of the occurrence, transmission, systemic impact, drug discovery, and prevention of COVID. And the solution for these posed challenges in infrastructural, operational, and cultural fronts. The pandemic has highlighted the immense importance of basic medical science, which were pivotal in isolation of virus and devising vaccines, testing for antibodies or antigens, and such kits have boosted testing capacities without the need of highly specialized equipment or lab. While in the midst of COVID-19 crisis, it is crucial that the academic educational community learns from the experience and prioritizes a forward-thinking and scholarly approach as practical solutions are being implemented. Reflection and evaluation must follow. For educators, the expression "make your work count twice" and the plan for educational scholarship has never been more imperative. One area in which students can serve and have a positive effect as an educators to their peers, patients, and communities using the tools available through social media and other modalities to help influence behaviors in a positive way. The COVID-19 epidemic may represent an enduring transformation in medicine with the advancement of telehealth, adaptive research, protocols, and clinical trials with flexible approaches to achieve solutions. There are many examples whereby learning from difficult experience of the past, emergence of HIV, response to disasters, change discovery, science, and patient care. Students and educators can help document and analyze the effects of current changes to learn and apply new principles and practices in the future. This is not only a time to contribute to the advancement of medical education in setting of active curricular innovation and transformation, but it may be a seminal moment for many disciplines in medicine. Plenty of technologies have become more widely accepted and interesting, not only to medical professionals, but also to general public, like telemedicine, artificial intelligence monitoring, to network medicine, all came together in an attempt to try to know, understand, and forecast the virus. Amidst this pandemic, the COVID-related point of care have evolutionized, and it is imperative that students and the medical professionals are informed about the new modules in basic medical sciences. I appreciate and congratulate the Department of Anatomy, Physiology, and Biochemistry for this initiative in conducting this international conference and wish all the very best. Thank you, one and all.
Thank you, sir. We are humbled and honored hearing your words. Now we have address by our chief guest, Dr. William Stringer. For this, I request Dr. Lakshmi Jatia, Professor and Head, Department of Physiology and Organizing Chairperson, to introduce our chief guest. Over to you, ma'am. Ma'am, over to you, ma'am. You can take over.
Thank you, Dr. Jyoti. Yeah. Dr. William Stringer. He is presently working as Professor of Medicine, David Geffen School of Healthcare, Division Chief of UCLA. Sir Siri, actually when I did this, and it was a mammoth task to reduce it to just one slide. Dr. William Stringer is Professor of Medicine at David Geffen School of Medicine, that I have already told you, and his lifelong focus is on improving exercise capacity in patients with a variety of heart and lung conditions, including chronic obstructive lung diseases, interstitial lung disease, dyspnea, HIV, exercise intolerance, preoperative exercise training, and heart failure. He also performs exercise consultations on patients with difficult to diagnose am I not audible?
Ma'am, you're audible now, ma'am. Now you're audible. You can proceed, ma'am.
Okay. So shall I start from the beginning or?
No, ma'am, you're very well
Okay, I'll
audible.
start again.
No, ma'am, you can continue, please.
Okay, fine. Okay, fine. Thank you. So he also performs exercise consultations on patients with difficult to diagnose conditions. Their research inventions include various devices, medications, behavioral therapy, and exercise rehabilitation. However, they firmly believe and advocate exercise is the best medicine. His interests also lie in the medical humanities and have over 15 lectures addressing various topics and involving medicine and art. He has authored 3 books and 10 chapters in exercise medicine and has more than 100 publications in national and international journals and has more than 200 presentations in various scientific forums. Apart from this, sir has many grants, research grants. Dr. William Stringer has also bagged many research grants from various institutions for his work. And Dr. Stringer is none other than the exercise medicine book, which has been written by the Stringer, the famous Stringer. Over to you, Dr. Stringer.
Oh, well, thank you very much for that very kind introduction. Can you hear me okay? So the good news is that Los Angeles is about 12 hours away, so it's nighttime here for you, early morning there. But thank you again, and thank you for the VMRF and ABMC for inviting me. I'm honored and certainly humbled. I will try to do my best with the keynote speaker, but just a couple of items that actually sort of been covered already, but I wanted to make sure we sort of talked about it. My background is in pulmonary and critical care. I've been active in the ICU in the last 20 months. I have to say it's been certainly the most difficult 20 months of my career. I think unprecedented has been used too many times, but it's certainly been an unprecedented period none of us have seen before. But it was really a time for medicine and technology and science to step forward and stand and deliver. And I think that that's what we've seen. And I'm very proud of that, that not only the science that has been advanced, but the compassion and the trying to help other people has been a tremendous outpouring for healthcare providers. But it's been a very difficult time for families and for countries and for research and for medical and healthcare. And even public health has been a very difficult area, what to do, and so much anxiety and so much difficulty with knowing what the future is going to bring. In the pandemic sort of mentality isn't good for people either. I think there's been a quantum lowering of mental health, anxiety, depression, those kind of things that we need to deal with. But it's also been a very tough time for education. in live education has a lot to be said for it. I think we've done an amazing job with switching over to Zoom conferences and video conferencing, but there's still something to be said, certainly in medicine, for being in the room with the patient, being able to touch them and being able to examine them and to reassure them. And that's been a very tough time for the families, not being able to visit their loved ones in the hospital. So that's been tough on the families, tough on the patients, and actually tough on the healthcare providers. We're sort of the second victim of what's been going on, lots of death and mortality that I would have hoped to avoid in my career, but here we are. So the last thing is that I think it's important for educators, healthcare providers, and everyone to remember the mindfulness, to realize there's a lot of good things in the world, and to use that to get through our day, because it's been a very tough time. As mentioned before already, is that there's really been a triumph of medical research. We've seen applied real world action to biochemistry, to anatomy, to physiology, to virology, to messenger RNA vaccines being produced, mass produced, put into clinical trials, and 40,000 people coming up with an answer and being ready to vaccinate literally in 1 year. That's a tremendous accomplishment that I think anyone who studies science would want to have that kind of home run in their career. So I'm quite humbled by all the things that have been done in science, and I think it should stimulate all of your students and all of your educators to redouble their efforts to use science to improve the world. I think that's its greatest power. We talked a little bit about testing and antivirals and clinical trials. Newer medications, oral medications are coming now, as well as obviously the hospital-based medications that we'll talk about a little bit in my keynote address. So the other one is, I think that we have to realize that there's also a lot of misinformation and a very low science literacy, understanding what a messenger RNA is, and whether that's, not understanding that DNA makes RNA makes protein, not understanding biochemistry can lead, I think, to people to have all sorts of crazy sort of magical thinking and mystical approaches to healthcare, when it really needs to be science-based. And I'm very impressed that your university and you're trying to educate younger people and make them science-based. So that's an important thing that we need to deal with. And social media, I think, hasn't helped us out much here with spreading a lot of myths and a lot of false news, fake news, that really made it more difficult to deal with this pandemic. So despite all that, and despite it being the toughest 20 months I've been through, I remain optimistic. I'm optimistic about healthcare. I'm optimistic about science. I'm optimistic about people, that we can come together and work. I'm optimistic about different countries and working together. And I think that it has actually shown a lot of the best virtues of us as humans, and that we are one race. We're all susceptible to the same virus, and we're the human race. And so I think it helps us understand that there's a lot more similar to all of us than different. And so what I like to conclude on is that the power of science is really to help humanity. And I would hope through education, through technology developments, through medicine, through caring for other people, having empathy for people that are less fortunate, that we really will improve humanity, and that we'll come out on the other side of this better, not only to deal with future pandemics, but also to deal with the usual healthcare challenges and economics and other things that have gotten so turned upside down in the last 20 months. So anyway, thank you very much for inviting me. I'm humbled, and I really very much appreciative of you putting on this conference. And it's going to be a very good conference, I think, with a lot of different important and interesting speakers.
Thank you, sir. Thank you for your insightful words. It's a pleasure and privilege having you here, sir. We also eagerly look forward for your keynote address too. the concerted efforts of the organizing team is what we are going to visualize now as an e-souvenir. In this context, I request Mr. Suresh Samuel, member BOM, to release the conference souvenir. Over to you, sir.
Thank you, Doctor. On behalf of the management of VMRF and also the organizing committee of AVMC, I release this souvenir for this conference.
You can download our souvenir from the link which we will be providing in the chat box now. And we are also sharing the soft copy of the souvenir in all the WhatsApp groups, and you'll also be sent through mail. Thank you. I now humbly request our Dean Sir, Dr. P.F. Couture, who was the pillar of support in all our ventures in organizing this conference. Over to you, sir.
Thank you, Dr. Jyoti. I wish good morning and good evening to all the resource persons, participants, and the dignitaries present over here for this wonderful event. And another milestone in the history of our institution, Arpadividi Medical College, Pondicherry. It's a matter of pride that in a consecutive second year, these departments of basic medical science departments, anatomy, physiology, biochemistry, and Center for Biomedical Research have organized this conference quite apt, appropriate theme, appropriate topic, and appropriate time it has been organized. I have my compliments to the team led by the organizing chairman, Professor Lakshmi, organizing secretary, Dr. Rajan, and other head of our departments of my biochemistry and director research and all of my colleagues. And I bring greetings from, of course, the management, the university at large, and all my colleagues over here, the vice principals, Dean HPE, MS, director research, all my faculty members of Arpadividi Medical College, and staff and students. And a couple of thoughts on this occasion. I am here to remark as a president of this function, I think the last event here. We all know that the education and research are two sides of the same coin, and both are inseparable. Absence of one leads to stagnation of the others. We're quite convinced about that. And the education shows the path for the research, and research shows the path for the education. That's what is a truth, real truth. Now we have been stuck with the pandemic for the past nearing 2 years, and both of the education and the research both have been affected. the direction, where it is leading has been changed, pace with which the changes have been happening, it has also accelerated. So if you think of something good about the COVID pandemic has devastated us, destroyed us, destroyed the mankind, it is a bane. But be from the other side of the coin, what are all good things that can happen because of this? Our wisdom lies in getting something good out of what is inevitable. So this COVID pandemic, I already said, has changed the path, speed, and direction of this education and research. It has been accelerated. I always say that the changes which have happened would have taken otherwise decades to change. And no doubt it has opened the doors in both education as well as research, so many opportunities for innovations and research. The necessity is the mother of invention, and so many innovations, research related to teaching, research related to basic science, everything has been opened up, and a lot of innovations have been happening. And on this such an occasion, so on this such a circumstances, these departments have organized this conference by creating a wonderful platform, international platform, wherein we have a resource person from all the 4 continents of the world. We have from the American continent, Australian continent, we have Southeast Asian continent, then of course our Indian resource persons, the speakers or scientists or teachers of national and international repute on this platform for next 3 days. I'll say that it is a wonderful scientific feast wherein varied topics or diverse topics are addressed on this single platform, which certainly sensitizes, makes one to brainstorm ourselves and think what we can do, both the staff and students, teachers. And this one another important aspect of this is they have created one more platform to identification of young research scholar. They have instituted awards, and amongst the faculty, amongst the PhD scholars, amongst the UG students, among the PhD students. That is another impetus or another booster, another encouragement or inspiration for the young professionals, young students to involve themselves in this venture. And once again, on this occasion, as the head of the institution, I'm sure that the next 3 days will be a very fruitful deliberations will happen on this platform amongst all the participants. And I welcome once again all of you and wish very fruitful deliberations to come. Thank you, welcome. Thank you very much.
Thank you, sir. Thank you for your presidential address. Thank you for your encouraging words too. We come to the end of this inaugural program. Gratitude is a powerful catalyst of happiness. Now, I request Dr. Rajan, Vice Principal and Organizing Secretary of this conference, to deliver the vote of thanks. Over to you, sir.
Thank you, Dr. Jyoti. Do you hear me? Respected dignitaries on the screen and off the screen, good morning to all. It's my honor and privilege to propose the vote of thanks on behalf of the organizing team of BMS Econ 21. I thank the organizing team for giving me this opportunity. On this occasion, I would like to remember and express our thanks to our founder chancellor. Without his blessing, this event could not have been successful. A special thanks to our chief guest, Professor Dr. William Stringer, Professor of Medicine, David Stefan School of Medicine, attending physician, pulmonary and critical care division's chief, respiratory and critical care, physiology and medicine, who despite his busy schedule has accepted to address on this occasion. Thank you very much, sir. I take immense pleasure to extend my sincere thanks to our Honorable Chancellor, Dr. A.S. Ganeshan, for the unstinted support for this conference. Thank you, sir. I thank our Honorable Madam Chancellor, Dr. Anuradha Ganeshan, for her kindness and valuable guidance for making this event a grand success. Thank you, ma'am. I extend my heartfelt thanks to Mr. Suresh Amal, sir, Member, Board of Management, and all other STP members, all officials from the head office, Chennai, for their guidance and encouragement in all our efforts. My sincerest thanks to our Vice Chancellor, Dr. P.F. Sudhir, and all other university officials for extending their support to organize this event. I also thank to our beloved Dean, Dr. P.F. Kotur, for his valuable contribution, where without his guidance and support, this program would have not been successful. Thank you, sir. My special thanks to Dr. Vishnu Bhatt, Director of Medical Research, Dr. V.N. Mahalakshmi, Dean HPE, Dr. K. Jayasingh, Medical Superintendent, for their guidance. I must mention our deep sense of appreciation for the core team, consisting of Deputy Medical Superintendent, VP Students Affairs, RMO, for their enormous cooperations for organization of this event. My heartfelt thanks to heads of various departments, faculties, residents for the valuable contribution for this event. I want to state the organizing team is most grateful to all speakers for accepting our invitation and making this conference more valuable. I thank all the speakers. I would like to take this opportunity to place and record of our heartfelt thanks to all the delegates of various categories for their support for the past 2 years. An event like this will not happen overnight. It requires planning and a bird eye for successful implementations. We have been fortunate enough to be backed by a very motivated and dedicated team of various committee members from all the 4 departments who worked beyond their comfort zone and made this event more meaningful. We should appreciate their tireless effort by giving big appreciation on this moment. I also thank our Deputy Registrar for the support to press and media contact. I also wish to express our thanks to the publication team, EDP sections, space and management, audiovisual team for their technical support for the success of the program. I thank Ms. Sri Lakshmi Nair, first MBBS students, for innovating the program. I also thank Dr. Jyoti, Assistant Professor of the Physiology, for mastering the program. I also thank all sponsors, and last but not the least, I thank the more and more event management team for their technical support and making this entire event grand success. Once again, thank everyone for making this event grand success. Thank you all.
Thank you, sir. Let us end this inaugural program with a national anthem. Kindly rise for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you. Now it's time for all the delegates to sit back and enjoy the scientific fest. Stay tuned online and our scientific sessions will follow. Thank you all once again.
పర్వాలేదు. A very pleasant morning to all the invited speakers, judges, chairpersons, and esteemed delegates for this international conference, BMS Econ 2021. The theme of the conference is exploring newer modalities in teaching, learning, and research in basic medical sciences during COVID era. As Aristotle said, well begun is half done. With the well-organized inaugural ceremony, our academic feast is about to be launched. At this juncture, I want to quote Henry Ford's words, anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. The greatest thing in your life is to keep your mind young. I invite you all for this keynote address by Dr. William Stringer. For this, I would like to invite our chairpersons, Dr. Omlata Bhagat and Dr. Vidyavati. Madam Dr. Omlata Bhagat
Good morning.
is presently working as Additional Professor, Department of Physiology in AIIMS, Jodhpur. Madam, she did her MBBS from Gajara Raja Medical College, Gwalior, which is good old college which has started before independence, and finished her MD Physiology from Mahatma Gandhi Memorial Medical College, Indore, which is started in the last century and renamed in 1948. She has her additional qualification and has expertise in autonomic, vascular, and pulmonary functions. As a lifelong student and researcher of physiology, she has many publications, around 18, 2 chapters and books, and 25 abstracts. And she is a resource person in many of the conferences like APICON and ASOPICON. And wherever you see exercise physiology in our conferences, we see her name. Innovation aspect, development of a user-friendly heart monitoring system, and developed a human voice-based instructive system and respiratory modulation at targeted frequency for pacing respiratory cycle. And she received her award in the year of 2015, Dr. Radhakrishnan Memorial National Teacher Award, being contributed as a medical teacher. And Madam Dr. S. Vidyavati, Professor and HOD of General Medicine, she is our second chairperson. She did her MBBS, MD General Medicine. Her vast experience of 20 years of UG experience and 14 years of PG experience, and she has guided many PG students, and she has 28 publications in national and international journals and books. Authored the chapter as on disorders of immune system in the famous book Apollo Hospital Textbook of Medicine, and her research areas of interest are diabetes mellitus, hypertension, infections, and clinical trials. And Madam has chaired many sessions in many of the national and international conferences. And over to you, ma'am.
Good morning, everyone. At the outset, I wish to thank the organizers for giving me the opportunity to interact at this forum of basic medical sciences research and education. I take privilege to introduce Professor Stringer for the session. We all know Professor Stringer. Professor William W. Stringer, commonly known among his colleagues and students as Professor Bill. He is an epitome of knowledge, a guru in true sense. He is my inspiration and guiding force. We all know that when we wish to explore exercise physiology and try to look the literature search, and also when we talk about the cardiopulmonary exercise testing, we can found his signature all over. To share some glimpses, he is the one of the authors of the Bible of Exercise Physiology, the Principles of Exercise Testing and Interpretation. His curriculum vitae runs in 42 pages. So it's a huge. And I'm too small a person to introduce such a great scholar of medicine and physiology. Presently, he is serving the world as a medical director at Lundquist Institute of Biomedical Innovations at Harbor UCLA Medical Center, Chronic Disease Clinical Research Center, California. We all know that he's a professor in medicine. He's attending physician in pulmonary and critical care. He's a division chief in respiratory and medical care, physiology and medicine. He started his academic journey as in biochemistry. Then he went to medical school for gaining his MD degree. Followed by, he has still expanding endeavors in the pulmonary medicine and critical care. His experience of more than 40 years in the field reflects his deliberations. The topic of his today's keynote address, the long haul COVID-19, is there a role of exercise rehabilitation to facilitate recovery, is an apt for the present scenario in India as well as the rest of the world facing this pandemic where nothing seems to be permanent. Now, I will not take much time and hand over to Professor Bill to share his thoughts and experience on the topic.
Thank you. I'm very kind there. If they'll let me share my slides, I can go ahead and get started. There we go. All right. Can you see the slides okay?
Yes, we can.
Yes, sir.
Thank you very much for that kind introduction. So I'm going to talk a little bit about exercise rehabilitation for what I call long haul COVID. It's all called long COVID or post-acute sequela of COVID, PASC, whatever you like. It certainly is a new disease that we're going to have to deal with. My background, as I mentioned, is in pulmonary and critical care. I consider myself a physiologist as well as a physician. I do both medical education and patient care, as well as research, as mentioned in that introduction. Thank you very much. Thank you for inviting me to give this talk, and I'm happy to take questions in the chat box as we get further into it. I don't have any disclosures that really conflict with this, but I am involved with both acute and chronic studies of COVID. I work in the ICU, and obviously, as mentioned, we have a cardiopulmonary exercise testing book that I'm associated with. So unfortunately, this little tiny virus has taken over almost every aspect of our lives in the last 20 months. I think this is a particularly good graphic because it shows all the organs that we don't see under the skin that are being affected by this. And we've spent the last 20 months really looking at the acute phase here. So the viral infection, the viremia, the inflammatory response, the recovery, and the vast majority of people. And that has been, as I mentioned before, just a tremendous outpouring of technology and science and medicine. But there's a tremendous number of people that have suffered from this, not only infections, but deaths. I'm sure the death number is over 5 million is vastly underrated. Some estimates are as high as 15 million. And I know that your country, as well as ours, has had a very difficult time with this. And my sympathies go to all the families that have been infected by this terrible disease. This is sort of another example of sort of at the bottom here, the pre-exposure, early treatment, and late treatment. Vaccines have been, as mentioned, just a tremendous success story, whether it's the Sputnik or the Moderna, Pfizer, AstraZeneca. Those have all been just tremendous insights and into the immunology of the disease, as well as obviously protecting individuals from serious illness. The antiviral pills I mentioned earlier will be oral, will be available in the near future. And I think that will vastly change the sort of dynamic of this disease. And I've spent a lot of time in the last year and a half with these medications, which are obviously a pound of cure rather than an ounce of prevention. Certainly dexamethasone and tocilizumab, anti-IL-6, and baricitinib, which is a JAK2 inhibitor. Those are really interesting mechanisms of altering the overexuberant inflammatory response. So what I want to focus on this talk is the other side of that graphic, looking at the different organ systems that are affected by this, and weeks to months to now years afterwards, we have data on what happens to these people after COVID in a smaller group of them. So I'm going to talk a little bit about some of the definition, the chronic symptoms and experience with LHC as long haul COVID or long COVID or PASC or whatever you like. I'll talk about some of the etiologies, talk about the physiology, the anatomy, and the immunologic changes that are associated with long haul COVID, and then talk a little bit of how we've set up a recovery clinic for long haul COVID, and specifically my interest, which is exercise rehabilitation, the use of that to mitigate the symptoms of long haul COVID, especially fatigue and malaise. So the definition in the United States by the CDC is the post-COVID condition to describe health issues that persist more than 4 weeks after a person is first infected with SARS-CoV. So that's a good diagnosis or a good definition, but the diagnosis is really more than that. There's a tremendous amount of symptoms that are associated with long COVID, and I'm going to go through those, but they can include autonomic dysfunction, obviously immune dysregulation, abnormalities of essentially any organ system. But there also is this multi-system inflammatory syndrome that we see primarily in children that has long-term ramifications for the people that are infected. And then we know being hospitalized and being in the intensive care unit, being sedated, intubated, paralyzed, ECMO, all those things have their own set of difficulties, regardless of what actually got you in the unit. So in the United States, there's at least 50 million known. And of course, that's an underestimate because the testing was woefully inadequate for months after the initial cases. But about 15% of the population. In India, known is about 34 million, or about 2.5% of the population. Again, I would guess that's an underestimate because of testing. We expect some number to go on to long haul COVID, and it really depends on what paper you look at. Some estimates are down as low as 2 or 3%, some are up as high as 30. I think 10 to 15% is probably a reasonable number. And it also it depends on how long after the infection and what symptom you're talking about. But that could be millions of cases in both of our countries. And the issue is that these people are frequently in their working prime, 40 to 50 years old, males and females that are in roles of not only in their education, but their work, their families, et cetera. So they become disengaged from all those things because of this very severe syndrome. And we don't know what causes it, the specific pathogenesis. This is a nice graphic looking at different organ systems, and what's common in neurologic issues, really memory, difficulty with concentration, difficulty with executive functions are very important. But from the psychiatric point of view, a lot of anxiety and depression. And I'll show you more data from Wuhan that's now a year out. In terms of pulmonary, cough is a persistent, very difficult symptom to treat, but they can go on to interstitial lung disease. And I think we don't entirely know how that's going to turn out in these people. The cutaneous manifestations, including rashes and cold fingers and toes and bluish discolorations, those are all very dramatic changes that are in certain people. The cardiovascular is really one of the most feared because of myocarditis, pericarditis, heart failure. But even bones and joints cause a lot of difficulty for these patients in terms of moving around, ambulation, et cetera. So there's really no organ system that isn't affected. This is another way to look at it. So the underlying comorbidities we know are the same ones that are predispose you to COVID, but diabetes, hypertension, obesity, et cetera. The miscellaneous factors are interesting. If they have more than 5 symptoms in the first week, females seem to be more likely to progress to long haul COVID. And then there can be other superimposed infections, maybe unleashing other viral abnormalities in the body that had previously been under immunologic control. We mentioned already the ICU and its downside for recovering, but older age groups don't do well. And then if there's persistent laboratory results, primarily neutrophilia and lymphopenia, but elevated markers of inflammatory response, and it can result in a deranged coagulation profile that's true in the hospital or even outside the hospital, including strokes, left ventricular clots, peripheral clots, deep venous thrombosis. So the mechanism isn't entirely understood. There's four sort of leading ideas. I'm going to go through those. The one really is pretty easy to understand, a direct cytotoxic effect on cells that have ACE2 inhibitor or ACE2 receptors. And so obviously the alveoli of the lung are very prominent in this, kidney, brain, they're all over. So it could be just a direct cytotoxic effect. The second one really is a dysregulation of the renin-angiotensin system, and that certainly occurs in some individuals where they develop postural orthostatic tachycardia, POTS syndrome. They have difficulty with standing, dizziness, difficulty with blood pressure and heart rate, and palpitations, arrhythmias. So that's certainly a possibility. The third one really is sort of what we talked about before with the procoagulant effect, endothelial damage, thromboinflammation. So as the inflammatory system of the immune system and coagulation actually have a lot of overlap, that there actually may be this endothelial inflammation that is prothrombotic. And we certainly see this in certain individuals. And the last one is, I think, the most interesting to me, and one of the things we're trying to understand better is this dysregulated immune response, especially the T cells, the Th1 response, and also that there may be cytokines or other inflammatory mediators, including antibodies, that are autoimmune in this process. So it may be a mixture of all of these. So I'm not saying they're all mutually exclusive either. Okay, this is well-known literature on post-ICU syndrome. I'm not going to spend too much time on it, but there's a well-known cognitive impairment, there's a well-known physical impairment, and a well-known sort of PTSD anxiety component. So separating that from long-haul COVID makes it very difficult to understand what's going on. And all those things are exacerbated by the amount of time, the severity of the illness, the severity of the therapeutic response, including sedation, intubation, proning, the ECMO, et cetera. And they require a lot of rehabilitation to fix these problems separate from what was the initial insult. So this is data in hospitalized patients with COVID. This is 6-month data from Wuhan. I'll present the year data a little bit later. This is about 1,700 patients, average age about 57. And they had fatigue and muscle weakness, sleep difficulties, and anxiety and depression at very high percentages at 6 months. And they took people that had WHO or ordinal scale of 3 to 6. Just to remind you, that's hospitalized all the way up to intubation, mechanical ventilation, but before things like ECMO. And it's people that are hospitalized and requiring some amount of oxygen, as well as this number 3 group. So they're quite severe individuals. So if you take those people and look at the green color here is the acute phase, and this orange color is the chronic phase. And I was just looking at your national flag. I guess we made this graph appropriately here. But the mild illness and severe illness, like this is fatigue, is very high percentages in the acute illness, whether it's severe or not. But if you look at the fatigue in the mild illness or severe illness in terms of post-COVID, this is 6 months out now, you can still see very high rates of fatigue in these individuals. And there probably is a dose response curve where severe illness has higher numbers than mild illness, but mild illness still has specific numbers here that that may indicate that it isn't just a severity of illness or a dose response. And that's interesting in and of itself. This is another way to look at it. This was a cohort study. They had individuals from several different countries, but a lot of it was Europe and the United States. They had COVID and they answered 205 symptoms in 10 organ. So if you think about somebody who would sit down and go through a 200 question survey, that might be a little different than the average person. But anyway, so 257 questions, 69 minutes on average to complete. Only 8% of these people were hospitalized. Most of them had experienced symptoms that persisted past 3 months, and 65% at 6 months. High percentage of women, in this. And again, working age people, 75% of these people are between 30 and 59. So this, I think, is fascinating as well. If you look at sort of the time course across the x-axis and the different types of symptoms, so mild and moderate are this blue and purple color. You can see the mild and moderate symptoms seem to be going up over this 7-month period. And the severe and very severe, which is this orange and this red, are actually going down over that period. So the more moderate symptoms seem to be taking more of a front stage as the time goes on. But there's still a persistence of symptoms, 14 in these people at 7 months. So a tremendous amount of symptoms that are continuing to occur. And 45% reported a reduced work schedule. So that's important in terms of overall productivity, being able to care for your family, provide financially, participate as a human being. And then 22% of them couldn't work at all. So this sort of multi-system prolonged involvement is having significant effect on their ability to do work, participate with the family, etc. This is from that survey, and what they found was these 3 most important symptoms: fatigue, post-exertional malaise, and brain fog up here. Post-exertional malaise is a symptom of after doing some effort, exercise, that they feel severely washed out, may take hours to days to recover after that. The post-exertional malaise is a very feared symptom in this particular constellation. If you take people who either have post-exertional malaise or don't, up here is post-exertional malaise. You can see very high rates up to 80, 90, 100%. Post-exertional malaise seems to track those very severe symptoms. If you look at people that either didn't have post-exertional malaise or the post-exertional malaise went away, their sign-symptom complex is much different, much less intense. So post-exertional malaise seems to be a marker probably of a very hyper-inflammatory immune response that persists over time, and maybe secondary organ damage from it as well. So if you think about the course of somebody's life along the x-axis from being very young to being very old, and you start out with a very high quality of life, and then say in your 20s, you develop COVID, there's sort of 3 trajectories that might occur from that. You might go back up to your normal health and never think again about the COVID infection. You might have persistent disability and persistent symptoms that reduce your quality of life, but you're still very active. And the third one is that you can have very severe symptoms that limit all of your quality of life markers and may even result in early death. So there's multiple different trajectories that can occur from this virus, depending on the host, obviously the severity of infection, the amount of time spent in the hospital, and the degree of immunologic inflammation. So this is a video that I would definitely recommend. We don't have time to do it today, but it's actually tracking the course of many different people that have had long haul COVID, some of them over a year now, and how difficult it's been for them, difficult for the providers, the physicians to understand their disease, and also the financial ramifications, lack of work, cognitive difficulties, etc. So I would recommend that. It's available on the web. It's free. It's about 9 minutes, and it really is a good way to get introduced to the type of signs, symptoms you get in long haul COVID. So just trying to divide it up into physiologic, anatomic, and immunologic changes. Let's start with physiologic. This is a group of people that were studied at the time of hospital discharge. So there may be a lot of, I guess, comorbid issues going on with these patients, but they tried to match that with people that were not hospitalized, one-to-one gender, age, BMI. And they did a pretty good array of testing, including spirometric echocardiography. They did cardiopulmonary exercise testing, and they did exercise echo with arterial blood. So what they found in this group was there was definitely a restrictive component to their pulmonary function as these people were coming out of the hospital. I don't think that's too too hard to understand. But the except for the mild hemoglobin difference, there wasn't too much else different in the laboratories of these people. If you went to their cardiopulmonary exercise test, what you found was their oxygen uptake was markedly decreased. Percent predicted was like 59% compared to essentially 90% in their controls. So a marked difference there. The other thing was there was definitely a dose response. Like this is abnormal FEV1. You can see it's much more common in severe than it is in mild. And same thing with gas transfer on the bottom left here. The more severe COVID had much more abnormalities of the pulmonary vasculature in this particular study. So the other thing that was interesting is that when they looked at the dead space to tidal volume ratio, essentially high VAQ, they found that these people, even at peak exercise, had abnormal values. Less than about 0.3 would be normal at peak exercise. So they had wasted ventilation, areas that are being ventilated but not well perfused. So this is actually an interesting study that just came out very recently. They took 10 people with long haul COVID and they did invasive cardiopulmonary exercise testing. So they put in a pulmonary artery catheter, they put in an art line, they're doing echo, they're doing CPET, and they're putting all that information together. So it's a little bit of a three-ring circus. But those people that they studied, their peak VO2 was only about 70% of predicted versus controls that are also presented for dyspnea evaluation but didn't have COVID. They found those people are being above their predicted values. They really found an impaired systemic oxygen extraction. So the normal number at peak exercise is about 75%, 0.75. You can see these people had abnormalities of oxygen extraction across their vascular bed, which again, I think is interesting and certainly needs more study. They did have high ventilatory equivalence, and they did not find a high dead space to tidal volume in this particular group. Most of these people had had long haul COVID for 8 to 10 months. So a different group than those immediate discharged hospitalizations. Again, they found a low peak oxygen uptake. In terms of mils per kilo, it was 16, which is quite low for a young group. The peak mixed venous PO2 or saturation was abnormal in the post-COVID, 50 to 22 in terms of the peak mixed venous. You'd expect this to be much lower, and the saturation would be much lower, and the venous PO2 would be much lower, something like these numbers here, 75% or so extraction, and a mixed venous PO2 coming back of 15 to 20. So the peripheral oxygen extraction is abnormal in these people. There was a high ventilation to VCO2 number at the anaerobic threshold. The peak oxygen extraction, as I mentioned, was abnormal in these people, was low. And they found that the cardiac indexes were actually very similar in the group. So this wasn't a central myocardial abnormality. This is a peripheral oxygen extraction abnormality. But they did find that there were low central pressures in these people. So there may be an abnormality of venous tone, specifically small vessel nerves that bring the blood back to the right heart and then deliver it to the left heart. So you can see that the right atrial pressure is low, the mean pulmonary artery pressure is low, and the pulmonary artery wedge pressure all are much lower in these post-COVID folks. So there does seem to be an abnormality of venous return separate from AV extraction. Okay, so just to summarize, mild restriction on the PFTs, low DLCO gas transfer, and exercise limitations. It looks peripheral. They don't really have a ventilatory limitation, but they do have some degree of inefficient ventilation to perfusion. That's the physiology behind that, at least is where we understand it right now. This is comparing people who had long haul COVID to controls. This is another more recent study, and they didn't actually do invasive testing, this non-invasive testing. But what they found was that these groups were not so much different in terms of exercise testing, even though they were both complaining of dyspnea. So this is part of the early literature in any new disease is you're going to get conflicting results and you're going to have to try to decide what it means. Part of it is that, these are very small studies, 10 patients, 18 patients, et cetera. So it takes some perseverance to come up with, I think, what will be the right answer in these people. But obviously 2 conflicting studies in a very short period of time. Separate from the physiology, I think is interesting is the anatomy. So what they did is they took people that were 2 to 3 months after their COVID hospitalization. So these were fairly severe, and they did essentially a multi-organ MRI, and they compared that to uninfected controls. And they focused primarily on the brain, the lungs, the heart, the liver, and the kidneys. Those are all areas that we think are definitely affected by the COVID virus. And they also did some physiologic testing, including spirometry and CPETs and some questionnaires. So what they found was that they had the usual sort of comorbidities. What they found, these people had been hospitalized for about 8.5 days, which is actually quite a bit of hospitalization. And then some of them had been readmitted, 17%. So these were fairly severe patients. What they found was that even at 3 months, 2 to 3 months after discharge, 60% of them had lung parenchymal abnormalities, ground glass opacities, some degree of fibrosis, and that this was markedly different than the controls, which only showed 10%. For a variety of other reasons, they got admitted. So the lung parenchyma remains abnormal, and maybe some of the etiology of cough, dyspnea, and the abnormal gas exchange, gas transfer being abnormal. The other part was the brain, and they looked at sort of the volume of white matter hyperintensities, which shows inflammation. And you can see that the COVID patients were quite a bit more, not quite double, but close in terms of the white matter hyperintensity. So there's ongoing CNS inflammation, and this is likely what's behind brain fog and difficulty with executive function. But exactly what this means and where it is in the brain wasn't actually specified in this particular study. So this is a graphic that they use to show, this is exercise data here, and using ventilatory equivalence as a function of white count. You can see as the white count goes up, the ventilatory equivalent is going up. So having neutrophilia or elevated white blood cell count is a marker of ongoing inflammation. They also had high ventilatory equivalents. They had low VO2s. And if you go from sort of a peripheral muscle thing to a brain health, you can see that they have higher number of densities in the brain. The Montreal Cognitive Assessment, which is assessment of cognition, is actually lower in those people. And again, those abnormalities seem to track something that we can easily measure, which is the white blood cell count as a marker of inflammation, separate from other more sophisticated markers of immunologic activity. So if you take these people that have COVID, this is the blue inner line, these are the people that had their controls. And you can see that it's not perfect. They weren't at 100% for all these things, but they were markedly exceeded the COVID group in terms of physical roles, emotional roles, pain, functioning, etc., social well-being. So there's a marked drop-off in all those segments of their lives. So I think this is where the money is, but well, I guess time will tell. It's very interesting, actually. The SARS-1 and 2 actually does attack the ACE2 receptor. The dipeptyl peptidase is what MERS attacks. But when you look at what happens, the mortality with MERS, which is very high, 30 to 35%, is very similar to severe COVID. Mild COVID, obviously, much less than 5%. It's probably less than 1% or 2%. And then the original SARS had a mortality of about 5 to 10% back in the early 2000s. So it's something like MERS in terms of its mortality rates. If you look at the abnormality of the immunologic profiles, when you get to severe SARS-CoV, which is the brown here, they have a neutrophilia, but otherwise, actually, there's a neutropenia, there's a lymphopenia, both CD4 and CD8s are actually reduced in this group. And then the flip side of that is that the inflammatory markers are all quite high. Doesn't matter whether it's MERS, SARS, SARS-1, SARS-2, or the severity of it. And then if you look at these particular organ systems we were just talking about, there's not a lot of difference in all these. SARS-CoV-1 and SARS-CoV-2 can cause very similar abnormalities in all these different areas in terms of their immunologic overactivity. So if you think about sort of predictors of poor outcome, we already talked a little bit about this, the leukocytosis, neutrophilia, lymphopenia, and it does seem to see both CD4 and CD8, the new end-to-L ratio, which comes out of that, the pro-inflammatory cytokines, IL-6, TNF-alpha, the Th1 cytokines, interestingly, IL-2 and interferon seem to be up. And then some of the regulatory cell cytokines, IL-10 and Th17, IL-17, also seem to be abnormal in this group. So it's really a broad-based immunologic overactivity that seems to persist over time in these people with COVID. So they seem to have a lot of autoimmune inflammatory diseases like Guillain-Barré, autoimmune type antibody syndromes, abnormalities of Th1, as we mentioned, and sort of itis of everything. It could be myositis, it could be arthritis, it could be dermatitis, it could be cerebritis, etc. And autoantibodies seem to be elevated in these people, and it's not clear whether that's actually a marker for severity of disease or the type of disease they'll manifest, or whether it's a secondary finding that's true but unrelated. And it's interesting that I see a lot of lung cancer, and we use the program CellDeath, the PD-L1 inhibitors. And what that does is it actually unlocks the Th1 in a lot of different organ systems, including brain and lung and muscle. So there's a similarity there that strikes me that may or may not be true when you get into the actual immunology of this, but it is interesting. So we now have 1 year outcomes from Wuhan, from that 1,276 that were hospitalized the first time. They got them back, and now assayed them at 12 months. They compared that to people that were living in the community but didn't have SARS-CoV. At least one sequelae was decreased. It went down from 68 to 49%, but still 1 out of 2 people had at least one symptom that persisted at from 6 months to 12 months. Dyspnea was very common, 30% at 12 months, so 1 in 3. And then anxiety and depression were common and actually went up from 6 months to 12 months, which is fascinating as well, that their psychologic approach to life had actually gotten worse, not better. And then females seem to be at greater risk for this, but most of them had returned to employment. And again, this is the WHO rating between 3 and 6 here, is the group that they assessed. So this is fairly severe people. If they look at any symptom, that went from 68% in 6 months here down to 49%. Fatigue and muscle abnormalities seem to be one of the more common things, but went from 52% down to 20%. But if you look at any one of the symptoms and then go up on this WHO ordinal scale from 3 to 4 to 5, 6, those are all progressively more ill people. You find more of any of these symptoms as you go across the board. So there does seem to be, again, a dose response, but it's not perfectly mirrored in the data. The other thing that's interesting, I think, from the physiologic point of view, is their 6-minute walk was pretty low and remained low in all these different groups of the different ordinal scales from 3 up to 5 and 6. It was about 495 or so, which is interesting. And it doesn't seem to have changed much from the 6 month to the 12 month. So these people weren't gaining any kind of physiologic function over that interval, which again is a little bit depressing. So the DLCO, if you looked at that from 6 months to 12 months, it didn't change very much, specifically in the group that required high flow oxygen. the percentage actually is much higher that they remained with abnormalities of gas transfer. But even in the scale 3, which weren't requiring oxygen, there clearly was a damage to the pulmonary vascular bed. Also, if you looked for ground glass opacities, which we saw in the other study was MRI, this is using CT, there was still a very high percentage of ground glass, up to 40% in the group, even at 12 months. And again, it seemed to be tracking towards higher numbers in this 4 and 5 and 6. Okay. All right. So that's the problem. What are we going to do about it? So that's the $64,000 question. There is a website that's set up now, the CDC. There really isn't much there. It talks a little bit about how you might assess for these symptoms, but it doesn't talk at all about what you would do for them. There's a couple of articles that have come out, which are essentially kind of what I do to take care of them, but there really isn't any great data. So what I'm going to talk about is exercise rehabilitation and try to convince you that this may be a way to treat these people and their symptoms. It has been used already in patients that are post-hospitalization. So this is immediately after hospitalization, which isn't necessarily making the definition of long-haul COVID. But they did 3 weeks worth of therapy after the hospital, 25 to 30 sessions. These are really intense rehabilitation. And it was adapted to low 6-minute walks. They started out with a very low intensity. But they had reasonable outcomes here, and they compared the COVID patients to other patients that went into pulmonary rehabilitation for COPD, for interstitial lung disease, et cetera. And what they found, well, this is the type of exercise they did. They did endurance, gymnastics, outdoor walking, strength training, relaxation, respiratory therapy. And this is the group of the post-COVID and other types of lung disease here. The post-COVID group actually was a little bit heavier and a little bit higher percentage of females in the lung group. Otherwise, pretty similar. And a usual sort of comorbidities. I'm not going to spend too much time on that. What they found at discharge from pulmonary rehabilitation is there was still persistent abnormalities in restriction and reduced DLCO. But they did find that the 6-minute walk actually went up. So this lung disease is the blue and the COVID people are the red here. You can see that the COVID people are actually a little bit lower in terms of functional status at the start of rehabilitation. And again, 200 meters is a very low functional capacity for 6-minute walk. And they went up quite a bit. Both groups went up, but COVID actually went up higher, getting closer to 350 or 400. The paper I showed you from Wuhan had numbers in the sort of the 495 range. So still much higher than both of these. Okay. There is a lot of stuff out there. We talked a little bit about social media and whether it's good or bad, but there is a long-haul COVID group on Facebook. There's a lot of long-haul COVID support groups. There's now an NIH study looking at post-acute sequelae of COVID. They call it PASC. I found this graphic actually when I was doing the lecture about 6 months ago. I just really liked it, showing the virus really holding back people from their actual potential. And obviously this is a support group that's available in India. So what we know about long-haul care is obviously not to get it in the first place. So obviously vaccinating people, and India is well over 1 billion vaccinations now. That's really tremendously impressive. Research we're going to talk about, trying to understand how we could maybe have activated some of these other viral syndromes that may be causing this syndrome. And it may be not actually COVID, it may be other viruses like HH6, other things that have been associated with chronic fatigue syndrome. And then I think it's important to make a holistic approach to the patient. You know, these are human beings you're taking care of, trying to design the best program for them and to believe the patient. A lot of these patients go to doctors and they're told that there's nothing wrong with them. They're having an anxiety attack, whatever. So it's important to realize that these patients are out there and in greater numbers than we've ever had before. At Harbor here, we actually have a very challenging group, a multilingual group, multicultural, low health literacy, socioeconomic status, a lot of homelessness, and not too high of technology sophistication and a lot of issues with addiction. So our group is a challenging group, but what we try to do is to create a one-stop shop for them for long haul COVID, where we combine multidisciplinary approach to the individual. And we use a lot of video visits as well as on site. And we try to make it as patient focused as we can. And some of the models that are out there already are the chronic fatigue or fibromyalgia, chronic Lyme disease, chronic EBV, what they used to call neurasthenia. Those are all kind of models that are probably going to have something to do with what we're doing in long haul COVID. So in terms of research, this is WHO and Cochrane. They're trying to classify the type of data that's coming out. I thought this was interesting. So the different colors here are the different speckled patterns or whatever. 4 is like the worst evidence, 3 is so-so, 2 is not too great, and then 1 is the best we got. You can see that the little dark bar is at the top of every one of these things. These are the number of publications. So the evidence, quality of evidence out there in terms of taking care of COVID isn't great, even though it's being generated obviously by scientists. So we have to get bigger numbers in order to understand this. And we do need placebo-controlled trials and other things. So rehabilitation does not have a great history of high quality papers. So in trying to create a clinical trial that's going to be successful, obviously you need to do a literature review. I just showed you the literature review is not so great, but then you have to evaluate what your core competencies are. So here for us, we have physiologic competency, I think, in terms of pulmonary function testing, exercise testing, rehabilitation therapies. So we wanted to try to use that and our competencies to try to help this group. After sort of thinking about what we would do, we talked to interviewed patients and community and support groups to try to get their feedback on what the challenges they've had, what has worked, what hasn't worked. And we built that into the protocol and then actually reviewed the protocol with community members and other colleagues that are dealing with long haul COVID at other sites. So I think that's the way to have an integrative approach to get the optimal protocol to design. So I'm going to show you the protocol we're working on. I don't have data to show you just yet, but hopefully early next year. But our inclusion criteria is obviously having long haul COVID, but a lot of patients actually weren't tested when they got sick. So we prefer to have them documented by PCR, but we're able to take patient report. We do primary adults here. I don't do pediatrics, and that it's at least been 3 months since their infection, and they have a persistence of some symptoms: fatigue, dyspnea, exercise intolerance, the post-exertional malaise I mentioned, and difficulty breathing and/or difficulty breathing. It's a 12-week rehabilitation program, two visits per week, 2 hours each. And the exercise training is a gentle progression between about 10 minutes all the way up to 6 minutes, using a mixture of treadmill, bicycle, and actually outdoor walking. And we're strong endorsers of interval training, even in actually quite incapacitated patients. And then we have a component of education that involves breathing techniques, stress reduction, nutrition, hydration, health literacy, understanding their disease. But I think that the most important thing is actually assessing whether they have post-exertional malaise. As we saw, those people actually are much more impaired by their disease. And so when they come in, we're going to assess for post-exertional malaise. I'm going to show you that. And we're going to use as a primary endpoint in the people that can actually exercise an improvement in peak oxygen uptake, anaerobic threshold, work rate at 12 weeks compared to a regular comprehensive program, which we have data on. And then a low intensity rehab program for these people that have post-exertional malaise. So they would be getting the educational component, but not the physical exercise, as long as their post-exertional malaise persists. And their endpoint would actually be related to this perception of their post-exertional malaise. And they would be participating in a very low intensity of virtual rehabilitation rather than on site, as opposed to the other group that would be on site. And the secondary outcomes are essentially general quality of life with SF-36, reduction in the cumulative score for fatigue and dyspnea, and then post-exertional malaise, I just mentioned. We were very interested in trying to use exercise to improve anxiety and depression scores. And then we're going to assess for different pro-inflammatory cytokines pre and post-exercise to understand how their immunologic adaptation is to exercise. And finally, we'll look at the sleep quality because it's actually quite fragmented in this group as well. So I'm going to take you through this flow chart real quick. It's a little small, but I'm going to blow it up here for you. So if you take this very top here, we already mentioned the inclusion criteria, age greater than 18, persistent symptoms three months after the initial diagnosis. And the evaluation, obviously, usual questionnaires, pulmonary function test, cardiopulmonary exercise testing. We also do a NASA lean test, which essentially is leaning against a wall and watching what the heart rate and blood pressure does. These people with the postural orthostatic tachycardia or POTS will have an abnormal response to that. So those people likely have an additional autonomic instability that we need to actually take into consideration. We do overnight oximetry. And I'm going to show you the 2-day CPET testing protocol that we use in this group. And we also do activity monitors, symptom diaries, and we use R to R variability as a marker, again, of some autonomic insufficiency or abnormality, and then a blood immunologic profile. So the post-exertional malaise comes out of this 2-day CPET testing. So what we do is on the first day, they do a CPET, and they come back 24 hours and do another CPET. And in normal individuals, those numbers are almost identical. In fact, sometimes a little bit better on the second day. But people with post-exertional malaise, chronic fatigue, can have a change in their oxygen uptake, their AT, their peak work rate, and that's identified the second day. And you also keep a diary and to see if they actually develop post-exertional malaise. This is a meta-analysis of a bunch of studies where they looked at this protocol. It actually does seem to have some validity in this group, at least chronic fatigue. We're not absolutely sure about long haul COVID. And this is a questionnaire where they look at sort of the feelings you have after exercise, mentally tired, physically drained, those kind of things, the frequency and severity of that over a period of time, and then to reuse that questionnaire to assess for improvement in these people that have post-exertional malaise. So the post-exertional malaise really bifurcates here. So if they don't have post-exertional malaise, they do educational things, as I mentioned, things about breathing and yoga, nutrition, relaxation techniques, pacing themselves, energy quantum, meaning there's a certain amount of energy they have for the day. So they have to take it easy on that, keep some reserve, relaxation techniques, and aerobic training, as we mentioned, going from about 10% or 10 minutes up to about 60 minutes, a mixture of bike, treadmill, outdoor walking, and using intervals. So that would be sort of a standard pulmonary rehabilitation program. If they have post-exertional malaise, then they would get the educational components, maybe some stretching, yoga, hydration, nutrition, counseling, educational things, but they wouldn't be doing the aerobic component of it. And if their post-exertional malaise worsens, then we actually even further reduce the intensity. We may take down the stretching or other things if that's actually exacerbating them. If their post-exertional malaise resolves, then they can move over into the other side and actually begin as a gentle aerobic exercise training. And we actually use the 6-minute walk to scale them above and below 200, as well as the cardiopulmonary exercise test. So the exercise program is uniquely scaled to the person who's going to undergo it. This is an example of the 120-minute sessions. There's usually a review of their diary and see how they're doing, stretching and warm up, 60 minutes of exercise. This won't be when they first started, maybe 10 minutes. And then stretching and cool down. And next interview, we sort of get an idea where they're at, both mentally and physically, and how they're doing with the training protocol. So this would be on site for the people without post-exertional malaise. If they have post-exertional malaise, they would they'd be doing this virtually. Finally, after this 12-week program, 2 times a week, they would come back for the same kind of evaluation, all the things we just mentioned, and look at outcomes, whether it's CPET or whether it's post-exertional malaise type symptoms. The other part is questionnaires, as I mentioned, to get at many different parts of this: sleep quality, overall quality of life, depression, anxiety, and there's even a post-COVID functional status scale that we're using as well, and a mini mental status, which is administered to look for fairly gross cognitive defects, which I don't think we're going to find, but we put it in there anyway, and then a dyspnea evaluation. And then finally, these are the immunologic protocols that are laboratories that we'll be looking at, sort of the standard things to make sure that there isn't abnormalities of either thyroid or heart, make sure there isn't blood clots or high D-dimers, persisting high ferritins, but standard cytokines, and then flow cytometry that we'll be doing pre and post exercise to look at the changes in those groups as exercise is proceeding and the rehabilitation program. So this is our rehabilitation area. We have people that have worked with us for a long time with pulmonary rehabilitation. And this is a new group of people, but an old therapy, which is rehabilitation, probably goes back 35 to 40 years. Some of our nurses actually have been doing this for a great long time. So we're anxious to get going on this and hopefully make a difference in these long haul COVID people. The great thing about exercise is it can be widely available. It's not expensive. It does seem to help both the psychology of anxiety and depression. It helps with muscle mass, body mass index, those kind of things. And the question is whether it actually improves or worsens the immunologic status. So you have to stay tuned. We'll hopefully have data for you soon, but we're working through all the IRB things right now, which is never exactly easy, but we're almost done with it. So we'll be starting probably in mid-December to early January. So anyway, that's the end, but of course we know with long haul COVID, that's really just the beginning, and I'm happy to take any questions or thoughts or ideas that you have. And I'll stop the share and we can take any questions that may have come up.
Thank you, sir. It was an excellent talk and it was indeed a feast to listen to you. And sir, as you have put it, the post long haul COVID has targeted the middle-aged women as against the acute COVID, which had targeted men. So that was the carry home message for us. And you have rightly put, as we have to believe the patient. So we should not dump them as functional, whatever they say. And almost all the organs have been affected. And you have also stimulated us to take up more research on this long haul COVID, which we have just started here, sir. And we have also come across patients presenting with Guillain-Barré syndrome, and many patients who had more than 5 symptoms during the first week of their acute infection, they have presented with this long haul COVID symptoms. Thank you, sir. There are a few questions. If there is time, we can take. Director Research, Professor Vishnu Bhatt, sir, wants to know, is there long haul COVID in vaccinated people?
Yeah, that's an interesting question. If you ask the people that have long haul COVID, most of them say that vaccination didn't help them, but there is a small group, and I'm going to say it's maybe 5% of the people that get vaccinated, that their symptoms get better. So it does have some kind of immunomodulatory effect in some individuals, but it's certainly, I wouldn't promise it to anyone that has long haul COVID, because the vast majority of them get vaccinated and they don't have a change in their symptoms. But there is a small group that gets better, but there's also a small group that gets worse. And most of the long haul COVID people would rather not get vaccinated just in case it makes them worse, because they're barely holding on right now. So I do recommend it, but most of them say that they would rather not do it. But the vast majority will not have any real change in their symptomatology. But there's a small group that gets better, a small group that gets worse.
There's one other question. Is there any gender preponderance for the post-exertional malaise?
Yes, there's definitely a female preponderance there as well. And actually, I don't know. I mean, there's all sorts of other disease models that have this female predominance, including lupus, chronic fatigue, and encephalic myalgia, those kind of things. I don't think anybody has an actual answer why that's true. There's lots of suppositions about different, estrogen effects, etc. But there really isn't any great answer to that. So that's certainly something that would be a fertile area to do research on, specifically the hormonal levels and the sort of fluctuation in the disease. So I think I may have misread that question, because the other question about long COVID in vaccinated people. So there isn't much data, but there is some people who actually develop COVID despite being vaccinated. There isn't much data, at least yet, in what happens to them, whether long haul COVID is less likely if they're vaccinated. I think that's what you're actually after. I sort of answered the other question, is whether you vaccinate once you have long COVID. But if you're vaccinated, you're much less likely to get a severe illness from COVID. And so the likelihood you're going to end up with long haul is reduced, but the actual degree or magnitude of that reduction. And then there are people still that obviously don't have a good vaccine response that still develop COVID. We're going to see some long haul in that group, but I would guess that the amount's going to be lower.
I have a question for you. What is the incidence of any new onset diabetes in the long haul COVID, sir?
I'm sorry, say it one more time.
Is there any new onset diabetes in long haul COVID patients?
Yeah, in terms of types of exercise, you mean, or I'm still not quite sure the question.
No, sir. Any patients post-COVID that have they developed diabetes due to the COVID? That is my question.
Yeah, I don't think anybody knows the answer to that one either. Obviously, there's a lot more questions than answers in this group. I certainly don't know the answer to that, but I'm sure that there will probably be more studies in the near future.
There are no questions. I think can end the session, sir. Thank you, sir. It was really a
Dr.
peaceful
Vidyavati,
session.
there
Yes,
is one
madam.
more question. There is one
Yeah,
more question, ma'am. Yeah.
I just
Yes, sure, ma'am.
are yoga, pranayama, or exercise which has more impact on COVID patients?
That's a great question too. We're using yoga in the exertional malaise folks, as well as stretching and therabands, which are isotonic. But it would actually be a great study to randomize to one of those three and see what happens. I think that there's other impacts to yoga and things that may mitigate anxiety and breathing and other things that may have secondary gains separate from the original intent of those areas. So I think it'd be a great study to do, to randomize people to one of those three or mixtures of those three, which may also be helpful as well. I think it's a great question. Again, we don't have a great answer.
Thank you, sir.
Well, thank you. Thank you for inviting me, and good luck with your conference. I think you're going to have a great group of speakers, and hopefully a lot of good science come out of this.
Thank you, Dr.
Thank you,
Stringer.
sir.
Thank you. Thank you.
On behalf of our organizing committee, BMS Econ, we'd like to show our token of appreciation and honor to our speaker, Dr. William Stringer.
Oh, thank you very much.
And also we would like to thank our chairperson, Dr. Vidyavati.
We thank the organizing team for giving me an opportunity to chair this wonderful session. Thank you.
And we like to thank our next chairperson, Dr. Omlata Bhagat. Thank you.
Thank you. Thanks a lot for giving me this opportunity to interact with the August gathering as well as to Dr. Springer. Thanks a lot.
Thank you. So we'll conclude this session, sir. And I hand over the mic to the next moderator for the next session. Thank you.
Thank you. Am I audible? Sorry.
Yes.
Thank you. Myself, Dr. Yasilan Kadir. I thank the BMS Econ organizing committee for giving me this opportunity to be the moderator for today's scientific talk. We have with us 3 scientific sessions today to follow, which will be presented by Dr. Dinesh Kumar Srinivasan sir, Dr. Kumar Satish Ravi sir, and Dr. M. Prakash Khante.
So can I introduce the speaker now?
1 minute.
So you're not audible, sir. Can I introduce?
1 minute. Am I audible now, ma'am?
Yes.
Yes. Thank you.
Okay.
Let's get into scientific session today. For sharing the session, we have with us 2 eminent professors. One, Dr. Deepti Shastri and Dr. Gunapriya Rakana. We have the scientific talk by Dr. Dinesh Kumar Srinivasan. So, sir will be talking on the topic integrating technology in blended learning, transforming the traditional modes of teaching and learning in post-COVID era. I welcome our chairperson for the session today. To start with, we have with us Dr. Deepti Shastri Madam. Currently, Madam is a Dean for Vinayaka Mission's Kirvananda Variyar Medical College Hospital, Salem. Madam has successfully completed her MBBS and MS Anatomy in Goa University. To add credit to her, she has been a president for Association of Anatomists during 2019 and until today. She has headed the department from 2007 to 2020. She has been a member board of studies for Kerala University, board of management for VMRF deemed to be university from February 19 until today. She has been a reviver for NPTEL medical recording since April 19. She has been an editor-in-chief for NJBMS. She has served as secretary for Academy of Dental Education. Also served as secretary for Society of Basic Medical Sciences from 2010 to 13. Madam has contributed for the publication around 37 in both national and international journals. We welcome you, ma'am. We also have with us our second chairperson for today's session, Dr. Gunapriya Rakana Madam. Madam is currently the professor and head of the department for Savitha Medical College and Hospital, Chennai. Madam has completed MBBS, MS, DNB, MBA, and FAGE, and Madam has contributed as serving as a member in National Program for Technology Enhanced Learning, a central government initiative organized by IIT Madras. Madam has received M.M. Cooper Memorial Award for Teacher in 2002. Madam has also received the Global Faculty Award 2020. She has received the Best Faculty Research continuously from 2018 to 20 by ACA Awards in Savitha Medical College. She has Authorship Award by ACA Awards in 2021 by Savitha Medical College. Madam has presented the best paper in international research presentation conducted in Abu Dhabi on the topic OSPI in Anatomy Modified. She has received the best teacher in anatomy in 2008 by Chettinadu Medical College. Madam has contributed around 49 original papers published in both national and international reputed journals. She has also authored Grants Dissectar, which is a South Asian edition published by Wolters Kluwer. We also welcome you, ma'am, for the session. Now, let's get into the scientific topic. I request the chairperson to introduce the speaker for today. Over to you, ma'am.
Yes. A very happy morning to all. I deem it my privilege and honor to introduce Dr. Dinesh Kumar Srinivasan, who is cluster at the Yong Lu Lin School of Medicine, National University of Singapore. He graduated in medicine from Government Stanley Medical College, Chennai, and obtained his MS and PhD degrees from the National University of Singapore. Subsequently, he has completed his postdoctoral fellowship in molecular cardiology at the renowned Cleveland Clinic and Case Western Reserve University, Cleveland, Ohio, United States. He has both medical education and basic science research interests. These include augmented reality for anatomical education, diabetes, congenital heart defects, tissue engineering, and device innovations. He has an extensive experience as a renowned teacher and has been actively involved in the development of modules as well as curricula for medical students at National University of Singapore. He has acquired several research grants and published over 50 publications in peer-reviewed international journals, including Nature, JBC, and Dermatology. He is an editor or member of editorial boards of 5 international scientific journals. He was awarded the Distinguished Long Service Award Medal for his contributions to education by Ministry of Education, Singapore in 2015. His accolades are much more and endless. We are happy to have you with us, sir. We are awaiting your lecture. Over to Dr. Dinesh Kumar Srinivasan. Thank you.
Thank you, madam. Thank you, Dr. Gunapiriya, madam. Can you hear me?
Yes, sir, you're audible.
Okay. Can I share my screen? Can I share my screen?
Yes, sir.
You cannot start. No, it says you cannot start share screen while other participant is sharing.
Pankaj sir, can make Dinesh as a co-host, sir.
Okay, now yes. Yeah.
Sir.
Now I can. Yeah.
Thank
Thanks.
you, sir.
Can you see my screen now?
Yes, sir. Your screen is visible.
Good. So, good morning, everyone. So it is a great pleasure and honor to be here with you today at the international conference organized by Aurobindo Video Medical College. I am thankful for this opportunity to make this presentation. This is my title of my presentation, Integrating Technology in Blended Learning, Transforming the Traditional Modes of Teaching and Learning in the post-COVID era. So before my talk, I take this opportunity to announce that the Department of Anatomy NUS organizing 6th International Anatomical Sciences and Cell Biology Conference 2022 in conjunction with our centennial celebration next year. This is a virtual conference. This will be held from 21st through 23rd February at the National University of Singapore. On behalf of NUS Medicine Department of Anatomy, my pleasure to invite all of you to participate at the 6th ISCBC conference. So our school is now ranked 18th in the Times Higher Education listing of the world best medical school. We continue to innovate in digital technology and devise new and cutting edge ways to deliver high quality medical education to our students and students globally. So the the world has changed and COVID-19 pandemic has been disruptive, but it has enabled us to leverage on the digital platform and redefine the way we teach. So moving forward, we should continue to consume new ways of delivering content to students in this digital age. To remain relevant and sustainable, we must be globally aware and competitive, and we also must leverage on technology, and we must understand new human needs. So for example, people who have never experienced life without the internet or the mobile devices, people may have experienced a different history and are deeply influenced by social media. People may need to constantly adapt. Potential is more important than knowledge and competencies. So with the recent increase on digitalization in medical education, that is especially pertinent in the current pandemic landscape. So our immediate priorities are to incorporate more online blended learning. Blended learning, also known as team-based learning, also known as flip class room teaching. Anything other than didactic, we call it as blended learning. And hybrid approaches as part of the curriculum to facilitate active and personalized learning. So there is a huge potential for digitalization and innovation to add value to medical education and to continue to healthcare. So a successful digital transformation will involve empowering educators to work in a new ways, including reskills and upskilling factors. So the innovative ideas and direction that I will share today were inspired by our school dean. So Dean challenged us to review our curriculum and assess current teaching methods. So here are the major points that we had discussed, whether our current program appeal to the generation Z student. I will talk about the G students in a short while. And also we need to know what sort of teaching initiative should we use and how to create an innovative culture and how to commercialize them. So we are interested in generation Z students. So these are students we are teaching now. So we have to understand our students better. Who are Gen Z students? They are self-starters, self-learners, and self-motivators. They are just as hungry as a millennial to have an impact in the workplace. So they take a few seconds to decide whether the content is worth their time and if it's benefit them. They also are likely to give feedback or review online. For example, 44% showed interest in contributing ideas to brands. So you can see here, people who were born from 1946 to now, we call it a silent or greatest generation. From 1946, sorry, before 1946, from 1946 to 1964, we call them as baby boomers. 1965, from 1965 to 1980, we call them as Generation X. Millennials are born from 1981 to 1996. People who were born after 96, we call it as Gen Z students. So these students are not anymore millennial students. So most of us here today, the speakers, we are in this the group. So Gen Z is also raised by entrepreneurially minded Gen X parents. So I belong to Gen X. So in fact, 40% of children today who are under 2 years old have used a mobile device and tablets and smartphones for playing games and watching videos and other media related purposes. So this is a trend that we will continue as more and more millennial become parents will make Gen Z hyper adapt as using technology. So in terms of generation differences, the key technology used by greatest of Gen X. So here you can see the greatest generation who were born early or before independence. And then you can see Gen Z students, Gen Z people or people here. So over the years, there has been a large technological shift. Technology is pervasive in the lives of Gen Z with augmented reality and virtual reality primed as the technology of the current generation. So Gen Z is raised by entrepreneurially minded Gen X parents that I had mentioned earlier. So there are two types of innovation, sustaining and disruptive. So sustaining innovation improves existing products. It does not create new market value, but developed existing ones with better value. So here you can see the sustaining innovations. So but allowing companies to compete against each other, sustaining improvements. That's why we call them a sustaining innovation. So disruptive innovation helps create a new market and a value network. The innovation eventually disrupts an existing market and value network. So the time is now right for us to bring about disruptive innovation and reinvent education. So we will have to think out of the box, and the pertinent areas being knowing more about design thinking and area of learning and designing future ready skills for the world. So, and finally, digitalization of medical education. So mixed reality is the use of both virtual reality and augmented reality technologies to create an environment where physical and virtual objects can exist and interact in real times. So the MR, the mixed reality, overlays images or videos over a screen showing reality through a mobile camera, smart glasses or headsets. So these are some innovative pedagogical approaches of teaching and learning at the Young Lulin School of Medicine, NUS doing. So these projects are developed and integrated into a strategic school-wide effort to improve students' learning experience. So the mixed reality has been introduced into our undergraduate teaching and learning in the Operation Theatre in offering students a more engaging and comprehensive experience. So in addition, MR technology also uses in a variety of other areas in healthcare, from undergraduate to patient education to home-based care. So we also have VIHA. VIHA stands for Virtual Interactive Human Anatomy. So basically this uses high quality, precise 3D virtual reality with year one efforts focusing on creating content for incorporation into the existing year one medical curriculum. So we also plan to, we have phase 2, plan to extend its collaboration with medical sciences other than anatomy, for example, physiology or biochemistry, and clinical sciences, and use new software and hardware platform to further segment its capabilities. So we have to redesign our curriculum to create values for our students. So this would promote self-directed, student-centered learning, which would lead to deeper learning, the acquisition of meaningful content, and consequently good educational outcomes. So these learning methods also would promote and develop domain-independent skills such as collaboration, respect, leadership, and then communication and research skill, professionalism and ethical behaviors, and lifelong learning skills to our students. So how do we deliver a world-class education? So in the NUS Medicine, we have world-class facilities such as anatomy table And then we also have plaginated specimens. We have e-museum. So in engaging the new generation of students, we should have a foster a digitally enabled environment where students can acquire the skills. So we have to teach clinically relevant medical sciences as expected of a house officer when they practice as house officer later. So we also have to make our teaching focused. So how do we enhance teaching and make every learning encounter inspiring? So we must create an enriching learning experience for students, such as blended learning and innovation, so that the application back into the real world is maximized. So in the preclinical years, we try to integrate subjects across disciplines, for example, anatomy, histology, embryology, with physiology and biochemistry. And then try to reduce the passive sessions. Passive means digital, not digital, sorry, didactic lecture. And if possible, we have to increase the incorporation of active learning method, the one I mentioned earlier. It's a blended approach. And then we need to use more of innovation. It could be both low or high levels. And then we also need to use of directed self-learning approach. So here you can see our students in anatomy hall. Anatomy hall, basically dissection hall. Students are provided, this picture was taken recently. As you can see here, they wear masks and also the goggles. So we provide them the e-learning materials, such as pre-recorded videos, and then they watch while they are at home. And then when they come to the hall, they study on their own. So I will share the directed self-learning in a short while. So in the coming years, we should adapt innovative approaches to enhance our teaching we have to continue to update. We should adapt collaboratively to enhance our educational qualities and better engage the students. We also have to update content according to curricular changes with the stronger links between the medical science and the clinical science. And we have to create longitudinal courses for clinical students and surgical residents, providing unique vantage points through professional skills with the fundamental knowledge for active learning. So we also have to enhance students' learning experience through co-teaching with the clinicians. So while you are teaching anatomy, for example, on hernias, you can actually bring a surgeon to talk about the surgical approach. So this could actually allow students to learn better even in preclinical years. But the focus mainly on basic medical science. So we should also teach our student to apply medical science principles of management for common conditions, and student learning is therefore associated with real situations. So this is the example that I had mentioned earlier. When you talk about hernias or any clinical related scenario in year one, you have to tell them why they learn this or the rationale behind the application part, the basic medical science part, when they apply to the clinical years or when they practice as a doctor. So we also have to develop clinically and surgically related educational videos. They are interesting and effective ways of students to access the content asynchronously. So we also have to encourage technology enabled and multimedia learning tools, which is blended learning too. I will share this in a short while for online didactic content, bite-sized, synchronized and asynchronized delivery. And also we could use pre-recorded or recorded and online assessment exams if possible. So we also must continue to conduct continuing education training. We call it a CET, which is recognized as very important. So the higher education institution have recognized the role of blended learning in enhancing teaching and learning quality. So many institutions have implemented blended learning initiatives as part of their quality enhancement efforts. So there have been pocket of innovative blended learning practices, but these practices are not prevalent across courses and programs within institution. There are 7 strategic dimensions in this framework: curriculum, vision, and policy. So you need to have a clear curriculum, and then you should have a vision, right? And then we need to have research and evaluation, and then partnership and student learning support, professional development, and finally the infrastructure. So infrastructure is also very important for blended approach. So again, in terms of domain of expertise, so domain of expertise, basically the advocates of technology in education name the new component of content knowledge as technological pedagogical content knowledge, in short TPA CK. This is said to be an interplay of 3 crucial elements of learning environment, namely content, right? You can see here content knowledge is important, and then pedagogical knowledge, and then technological knowledge. So you need to have all this expertise in order to move forward. So the blended learning 2, in NUS, we adapt blended learning 2. The blended learning 2 aims to continue in our educational mission through thoughtful use of online learning and assessment. So the blended learning 2 initiative is developed to support our teaching and learning activities as we continue to leverage on online or hybrid learning to help improve students' learning outcomes. So this includes bite-size and or pre-recorded or lectures, and then tutorial follows in person or online that can also be recorded. And student teachers can analyze students' learning activities, particularly online activities. And this help also teachers track students' progress and improve learning outcomes. So these are the observation from our 2 publications. So we have to incorporate more online blended learning and hybrid approach as part of the curriculum to facilitate learning, facilitate active and personalized learning. We need to facilitate, we need to adopt e-learning strategies such as the use of pre-recorded video lectures and videos as a pre-class material, as well as the online platforms such as MS Teams or Zoom for conducting live as well as interactive classes. And thirdly, we have to facilitate the interactive session using Poll Everywhere. So Poll Everywhere can be used to test students' understanding of the topic they have learned in the pre-class material through the interactive questions and to clarify their doubts. So the Poll EV is a platform that engages students across hybrid workspaces through live online polling, surveys, question and answers, and quizzes. So thus the implementation of the technology enhanced learning not only allow for individually enriched customized learning through the adoption of the state of the art, but also extend the pedagogical experience beyond the classroom. So these are the pre-recorded video lectures used as pre-class material for online blended learning in our undergraduate teaching. So my online interactive lessons kept students safe by limiting social contact while ensuring that they have received quality education, not compromised due to the pandemic. So I had engaged discussion with the students using Poll Everywhere that I had mentioned earlier, and clarify their doubts regarding the content. This was my first foray into the use of new innovative platform for online blended learning in 2020. So, so we have a platform called Panopto. So you can actually download this material into Panopto. Good thing about the Panopto is that you can analyze students' online learning activities. This helps us to track student progress and improve their learning outcomes. So I believe that this it is an appropriate learning tool for students to learn at their own time. So as you can see here, you can see in this the last graph, how many people viewed, and then how many minutes they delivered, and then how long the student took to complete to watch your videos. Even if someone just on and watch for 5 minutes, it can show with the name and the details that students watch only 5 minutes or 10 minutes, something like that. So yeah, I have created these practical videos to teach our phase 1 students. Phase 1 is basically year 1 medical students. These videos have been developed as a supplementary learning tool for practical lessons to allow students to the anatomical details firsthand through the screen. So this will reinforce the concept that will later they see in the anatomy hall. These videos allow for flexibility in learning, no matter synchronized or asynchronized. So this is the latest paper published by me in Anatomical Sciences Education. I published only a year ago, and then it was cited almost 60 over citations. So our students were positive about online classes. It is clear that implementation of effective online learning and inclusion of digitally enabled resources can provide a range of positive outcomes. So including developing a learning environment catering to students with different paces of learning. So this enables us to constantly find new innovative ways of teaching and using technology in my classroom, even in the post-COVID landscape. So these are some pertinent comments from students regarding blended learning. As you can see here, effort pre-lecture, professor put effort pre-lecture slides and videos effectively gave us a foundational understanding of the topic. And someone mentioned adding his voiceover on each and every slide in a slide. And then someone mentioned that request for pre-recorded lab sessions for better guidance and efforts to include voiceover in its slide, as well as ensure that pre-recorded sessions are released on time. And you can see the another student wrote teaches anatomy with a strong relevance to clinical application, which makes learning more memorable. So these are all the feedback that I had received from students. So in recent years, the surgery and anatomy departments have collaborated to create guided video tutorials using surgical footage to teach anatomy. So this is an anatomy. This is an example of a video how here I mean the how the inguinal hernia has been repaired. Or here you can see the colorectal surgeon working on a hernia repair in which I have been involved. So this project was funded by MEGIC grant, and it is a new initiative by the school to drive innovation in medical education and create a culture of innovation and entrepreneurship. So basically, this was recorded in the operation theater, and then we added voiceover, how to make incision like anterior superior, how to make the mark before make an incision. They need to know the inguinal ligament, for example, the inguinal ligament extend from ASIS to the pubic tubercle, and then they need to know where roughly where the direct, roughly where they can look for inguinal ring, deep inguinal ring. And then our students also expected to know whether it's a direct or indirect inguinal hernias. So all these were explained by voiceover and then also annotated. So as you can see here, it is labeled everything. And then they also have quizzes at the end of the videos, so that they can answer, they can move forward to next step, next level. So here is another example of what can be achieved through new cutting edge technology. We have developed an interactive learning application that enhances spatial understanding of students with lower visualization ability, in short VA, using 3D anatomical models. So Ms. Mandy Lee was a student last year. We worked together with my department colleagues and also colleagues from the School of Design and Environment. We collaborated with other school. Here the student is watching tutor demonstration on locking and unlocking of the knee and simultaneously manipulating a 3D printed model of the knee. So this creates a unique and learning experience of the student to connect what he has learned audiovisually with what he is feeling through the physical touch. So this integrated learning approach or experience provide a unique vantage point for active learning and retention of key anatomical content. So CAMS CAMS was introduced 5 years ago to year 1 medical students, basically to teach them the physical examination of the different systems. So cardiac auscultation provides insight into the diagnosis of patients with the various types of heart conditions. However, students have to be exposed with variety of cardiac condition in order to achieve competence in auscultation. So hence we have designed a more experiential learning experience specifically for students to practice cardiac auscultation skills, so as to overcome the limited availability and accessibility of patients with condition and costly simulator. So as you can see here, he is Prof. Vachi Paulina, is a chair of the Department of Anatomy at the Mayo. We developed this prototype, and then when student put the stethoscope over the 4 areas, they will be able to auscultate S1, S2 plus murmur. So you can this actually been developed by the by my group here. So this sort of innovation we are still carrying out in the department. Okay, so I'm going to change topic that now. So initially I mentioned how to deliver, but again we need to know how to prepare a future-ready workshop, future-ready workforce. So we need to have the insight to know where our staff stands, and we need to know, enlighten them on whether they need to be and what their roles are to develop these prototypes. And then we also have to inculcate their curiosity to keep learning and improving, and motivation to take charge of their own responsibilities. So they will also have to be empowered to change things for the better. And lastly, we need to know if they are engaged to work with others. So these are all the things you have to take care of. For closer collaboration, we should work closely with the medical sciences and clinical sciences, doing interdisciplinary strategic workshop together. And then clinicians should be further involved for better integration in preclinical teaching, and staff should be encouraged to identify competency gaps, and the department will provide opportunity for them to attend courses to fill the gaps. Most importantly, we should recognize staff contributions and promotions based on their and promotion based on their work excellence. So we will have to build and improve the culture of innovation among staff so that each staff feel empowered to make a positive difference where they are. So there are 3 phases in the digital transformation training. Phase 1 is digital fitness training. Phase 2, business process reengineering, and phase 3 is digitalization. So Industry 4 employs the use of technology such as big data, industrial internet of things, such as AI, augmented reality, virtual reality, and others to find solution to complex problem and make the assembly line more efficient. So we are responsible for preparing staff for Industry 4. So how to prepare for Industry 4? In order to prepare for this, we have to ensure that all our resources are up to date and equipped to face the new order. To achieve this, the training program have to be more scalable, personalized, and flexible to adjust to the dynamic needs of Industry 4. Staff should need to apply a variety of hard skills to combine know-how related a specific job or process, such as techniques for working with the technology competencies that range from basic to advanced or changing teaching tools. So to be even more open to change, possess great flexibility to adapt to new roles and the work environment, and get accustomed to continual interdisciplinary learning. So we are very fortunate that NUS Information Technology here provides training for all staff and students to create in the digitalized technology or digitalized materials for students. Okay, in summary, as mentioned earlier, we should incorporate online blended learning and hybrid approaches to facilitate active and personalized learning. And we will have to adopt e-learning strategies such as the use of pre-recorded video lectures and videos as a pre-class materials, as well as online platforms for conducting live and interactive classes. We must facilitate the interactive sessions with PolEV to test student understanding of the topics they have learned in the pre-class material through interactive questions and to clarify their doubts. And then we must facilitate, we have to teach clinically relevant medical sciences that I had mentioned earlier, and that is the link between the medical sciences and clinical sciences. And then we have to use more of directed self-learning, and we have to enhance students' learning experience through co-teaching with the clinicians and conduct more CET courses. With regard to the prepare future-ready workforce, staff should be encouraged to identify competency gaps, and then the school or department will provide opportunity for staff to attend courses to fill the gaps. Recognizing staff contribution and promotion based on their work performance. So in the coming years, we hope to continue to pursue excellence in medical education and strive to maintain our teaching standard by educating our students using modern evidence-based approaches. We will ensure they graduate well prepared to serve their patients and communities in a rapid changing healthcare environment. Together, we inspire health. That is our school vision. Together, we inspire health is our school vision. So we also more aligned to the school vision. And thank you very much for your kind attention. Thank you.
Thank you, sir. At the outset, I would like to appreciate your institution, your dean, who you credit with the transformation from conventional teaching methodology to blended learning, and you, of course, for the innovative teaching, learning, pedagogical approaches that you have adopted in this COVID era to engage the students effectively. We'll wait for questions from the audience. Till then, I think I will just pass my own comments.
Sure.
I think Dr. Krishnaveni has a question for you. Histology, how to work out with online teaching to see the exact slide.
Okay, we have again a digital platform. All our slides actually scanned with a high magnification or high resolution. I can't remember the name, but the person can write to me. I send you the details. So what our students do during the histology teaching, nowadays our students, they don't go and look at the slide under the microscope. So all these are online, and I'll send you the link. I'm not sure whether public can have access, but at least I can give some information. So what our students do during the practicals, they can via this, like this, the MS team, the lecturer actually use the platform to show the slide, low mag as well as the high mag, and then they will the person will take them through. For example, if they look at the duodenum, the lecturer will show them the Brunner's gland, and then in the low mag and the high mag, and then it is also annotated separately as a PDF format. So our students actually have slides with annotated information, and the other side actually they could see the tissue using the online platform. They can zoom in up to the 10,000, 25,000 magnification, such a very high resolution. And these are the things now we are using. Our students actually enjoying the histology classes studying by this method. So the details I can forward if the person wants. Thank you.
Thank you, sir. Well, I do endorse the view about the advantage of harnessing technology for medical education. But sir, could you still consider there's this thing called as digital overload? Do you feel students and faculty could experience digital fatigue, which could actually boomerang on the good intentions of technology? You have mentioned earlier that you were tracking the screen time of the students. And we actually faced, we struggled with digital fatigue issues of our students. So what do you have to say on that, sir?
Yeah, that's a very, very good question, madam. Even we also face the same problem. So we cannot force students to come and attend our lecture. So during my lecture time, I use as an interactive lecture. I'm not giving what you call the didactic or face-to-face. So I have already created the material for them to watch when they are free. So normally our students are very active in the night time. Daytime they sleep. Okay, but again the thing is it does not mean that they don't want to attend lecture. They as you mentioned, they have at least they have to watch at least 5 to 8 lecture. That means they have to spend 8 hours of lecture, which is really fatigue for them. So what because of this, actually we provide them the material in advance. So they no need to come and attend my lecture, but they can watch while they are free in the night time or evening time or during weekends, Saturday, Sundays. And then during my lecture, I don't show them the same slide, but I can put them some Q&A using the poll everywhere. And then they can actually clarify their doubts. So in that way, you can keep them engaged and also keep more lively and interactive, because again, you cannot expect 100% attendance in this interactive. Who learn, who had the opportunity to look at our material, they are the one actually come and attend your interactive lecture. So they don't mind actually fatigue. Again, depends on the person who whether the person is stressed or not stressed or taking fatigue. Again, all these were clearly mentioned during the medical admission interviews. These are all the things you will have to go through if you take medicine as a career. They all agree on it. So I tell them, joking. I always joking. Oh, when I interviewed, you said yes, but now how come only few people are attending? Then this is the way we could encourage more people. So to answer to your question, yes, we have no choice, but this is the way we have to move forward, and we had no other choice, and we cannot turn it back. I think COVID teaches the good and bad things, but I feel that I learn in my experience, I learned many good things preparing this digital material. Initially I never thought about, but now I created all the materials. So this is the way I have to move forward. I don't know whether I answered your question, but answer is yes, they are stressed. Yeah.
Thank you, sir. It feels good to know that another part of the world is going through the same kind of stress that we are undergoing as well, as far as disruptive educational innovations are concerned. We have run out of time. I think Dr. Krishnaveni has a few more questions. I'm sure the organizers will pass on these questions to you, sir. I would just like to say that it's been a moment of change for me as for the rest of the world on how medical education could be delivered. I had viewed online education as something a full-time adult employee could recourse to upskill, as you mentioned, himself or herself with the latest knowledge and skills, like, MOOCs, Coursera and such. But the emergence of the COVID-19 pandemic has turned tables. And you have rightly proved to us that disruptive educational innovation has replaced existing methodologies and modes of knowledge transmission by opening new alternatives for learning.
That's true.
Though digital transformation existed in higher education earlier, the pandemic seems to have accelerated it.
Yes,
And
exactly. We
thank
must
you
thank
so much.
COVID. Welcome, ma'am. Thank you. Thank you.
Madam,
Thank
with your permission, can I just ask a question or two, madam?
Yes, please go ahead, ma'am.
Sir, what is your take on virtual teaching being a part of a routine medical curriculum in future? What do you feel about it, sir?
As mentioned earlier, we have to move forward. I think in the future we have to do virtually, and there are good and as mentioned earlier, pros and cons. Basically, we have a material, and then we have to try to use them effectively, like what you call the blended approach. So I think now students, they used to it, and now they prefer online teaching. They don't mind actually watching videos and then come and ask questions rather than come and attend physical face-to-face lecture. So they also feel sometimes boring, and I also feel as an educator feel the giving the material or giving a didactic lecture at the end of 2 hours. Even I don't know whether our students learn the concepts. So I would rather put questions and ask whether they understand the concepts. So answer to your question, I think in the future, virtual would be the method that we all have to move forward. Yeah.
So virtual teaching is here to stay with us.
Sorry.
Related to your question itself, can I interrupt and
Yes,
since
ma'am.
it's
Please,
related to your
please go
question?
ahead, ma'am.
What we are discussing is technology in education. I feel it's okay for probably other courses, technological courses or arts and so on. But when it comes to medical education, I just want to mention about disruptive technology and medicine. I recently read this article, an interview, in fact, of a 2018 article of a doctor, a well-known doctor from Breach Candy Hospital in Mumbai called as Dr. Farooq Udwadia. And he was asked by the columnist, we can't wish away technology, can we? And he said, and I quote him, he said, no, but can science and technology ever be able to take a good history from a patient or take the place of a good physical examination? And no, he said, it's important to realize that your eyes, ears, and hands can sometimes detect what no technology can, unquote. So I just want to comment here that preserving human presence in medicine and safeguarding compassion in a digital age is important, isn't it? And I was just wondering, would there be any kind of a difference if a robot broke bad news to a patient's attenders as compared to a treating human doctor? And I would like to think so, that there would be a difference in a human, breaking the bad news. And since we start early, in medical education, from the first MBBS onwards, are we justified in providing predetermined answer keys and assigned points and automated feedback on Google Forms, which replaces the teacher's personal investment in providing a verbal feedback to a student on his or her performance? This is just my thought. Are we somewhere,
Actually, yeah. I had the same thought also, madam, but now I'm convinced. Actually, there are a lot of things can be done. Haptic, the one you mentioned, the feeling, right? So there's a haptic technology. Currently, we are working on doing abdominal palpation in the simulator. Actually, you will have the real feeling, when like how you palpate the abdomen. And then again, for the in the future, for example, in the pathology, right? So there are a lot of data currently loading, and in the AI, artificial intelligence, loading, and then to predict the cancer or whatever, right? So people believe that in the future, pathologists may not have a job, because after loading all the data and how to, how to, for example, identify the tissue, when you feed again the slide or whatever, right? The machine will give you the result immediately. They look at over million of the data, and then it can say predict almost close to what happened to the patients, and then so on. So again, imaging. So imaging in the past, we used to have take X-ray and then read in the box, but now everything you can see the X-rays in the computer and digitalize. And for example, we take X-ray here, and people in US or India, they read the X-ray and give comments. So again, all these, looking at all this, right? I feel that in the future, this is the way the medical education would be or could be. So this is my
take on it. Thank you so much, sir. Thank you so much.
Yes, sir.
Small question, sir.
Yes, madam.
What is your view on inclusion of telemedicine? What is your view, sir, on telemedicine being handled for CRI students?
Okay, actually, in our school, the people are working on the another project called WISE, VISE. The detail again, who are interested, I can share. But this actually create help or train our younger doctors. For example, the system. In the system, they can show the case. For example, the doctor can sit in front and then ask some leading questions. And if the question was not correct or wrong, the system can correct, the system can say, no, doctor, the question is wrong. And then you could think of something different. So, again, it's a virtual patient, the person sitting in front. And then exactly when you ask question, it will reply with expression. So that kind of technology is available there. So again, telemedicine, to answer your question, yes, it's possible, but provided if we train them properly, So yeah, the training is very important, madam. Even when houseman, you are saying houseman, house officer to do the telemedicine. Yes, we have to train them properly in order to take this job.
Thank you, sir. Thank you for your explanation.
Thank you, sir. Thank you, ma'am. I'd like to thank Dr. Dinesh Kumar Srinivasan, sir, for elaborating on this topic. I also would like to thank Dr. Deepti Sastry, madam, and Dr. Gunapriya Raghunath for sharing the session. As a token of appreciation, we would like to honor our we would like to honor our speaker today. I take this opportunity to honor our speaker today, Dr. Dinesh Kumar Srinivasan, sir. Yes, sir.
Can you make it a slideshow? Go for the slideshow.
Yes, sir.
Right, yeah.
Yes, sir.
Then you can, after the speaker, then you can go.
Yes, sir. Take this opportunity to thank our speaker today, Dr. Dinesh Kumar Srinivasan sir, for giving his topic today.
Thank you. Thank you, sir. Thank you, everyone. Thank you very much.
Thank you, sir.
So please feel free to write to me. I already messaged my email address, and yeah, if you, please, participate in the coming conference in February if your time permits. Thank you.
Definitely, sir. We also have got some queries in the chat box. We will share it to you, sir. You can
Yeah,
answer.
actually, if I exit, then I cannot see the question. Could you please?
We will share, sir. We will
Yeah.
send it to your mail, sir.
Okay. Thank you.
Yes,
Bye-bye.
thank you, sir. I also take this opportunity to thank our
Oh, yeah.
chairpersons.
Sure.
Chairperson today, Dr. Deepthi Shastri, madam. Thank you, ma'am.
Thank you.
And Dr. Gunapriya Langadher.
I also would like to thank our second chairperson for the session today, Dr. Gunapriya Raghunathan. Thank you, ma'am.
Thank you.
Sir, this side, Dr. Rajan, sir. Thank you so much, sir. Thank you, ma'am.
Thank you, sir. Thank you very much for your invitation. Bye-bye.
Bye, sir. Thank you, ma'am.
Thank you, sir.
Thank you.
Thank you, sir, for the wonderful opportunity. Thank you, sir.
Thank you.
Having completed the first topic for today, let us continue with our second scientific session. Which will be presented by Dr. Kumar Satish Ravi sir, and the session will be chaired by Dr. K. Shantini Arulselvi and Dr. M. Sivakumar sir. Dr. Kumar Satish Ravi sir will be briefing on his topic, research in anatomy, challenges and solution amid the COVID-19 pandemic. It's time to introduce our chairperson for today. To start with, we have with us Dr. K. Shantini Arulselvi, madam. Madam is presently the professor and head of the Department of Anatomy in Vinayaka Mission, Karaikal. Madam has successfully completed her MBBS and MD in Raja Mutaya Medical College and Hospital, Annamalai University. Adding to her credit, Madam is a life member of Society of Clinical Anatomists. She has also been a part of Association of Anatomy, Tamil Nadu. Madam has been as a resource person in Medical Education Unit, has served as external examiner for undergraduate students in Tamil Nadu MGR University, Sri Ramachandra University. Madam is a guide for PhD program in Vinayaka Mission Research Foundation. She has given a talk on a key to success in genetic and genomic competency at a national level conference. Adding to her credit, she has also published 10 scientific research papers in indexed journal. We welcome you, ma'am. Our second chairperson for today's scientific talk, we have with us Dr. M. Sivakumar sir. Sir is currently professor in the Department of Anatomy, SRM Medical College, Trichy. Sir has successfully completed his MBBS and MS. Adding to his credit, sir has been a former professor and head of the Department of Anatomy in JIPMER, Puducherry and Karaikal. Sir has been an editor in first South Asian edition of Moose Clinical Oriented Anatomy. Sir has been a president of Society of Clinical Anatomists, has been a member of Board of Studies for UG and PG courses in AIIMS, as subject expert in Selection Committee of AIIMS and JIPMER, has been an external expert for many doctoral committee, has successfully received a gold medal for his best paper published in Anatomical Society of India in the year 2003. Sir has contributed to his publication in both national and international in an enormous number. We welcome you, sir, to chair our session today. And it's time to introduce our speaker. Over to chairperson. Dr. Shantini, ma'am. You can
Am I audible,
introduce.
sir?
You are audible, ma'am. You can introduce the speaker.
Very good morning. Today is a wonderful day here. Just a sunny day in the rainy days. And I am very happy for the second International E-Conference 2021. Arubadai Vidu Medical College and BMS doing a wonderful job. Last year, you have successfully conducted a International E-Conference even in the pandemic period. And similarly, this year also, you have started the program successfully. And this session is a second session. And I congratulate all the persons for this successful conference. And I thank each and every one of you. By introducing the speaker, I think he is a wonderful researcher. He published several research papers in an international and national level. He received a 3 Best Paper Presentation Award 3 times. As a member, he is a life member of SOCA, Anatomical Society of India, Indian Society of Human Genetics, and he is a regular member of the American Association of a Clinical Anatomist. And he is the one and only person who presented the paper in American Association of Clinical Anatomists. As a teacher, he is a best teacher. He received a Best Teacher Award in 2018, and he received a Best Professor of Year Award in 2021. As a editor, he is associated with several editorial board, and he is a reviewer of renowned journals, especially clinical anatomy. And he is the first editor who edited the clinical Snell's neuroanatomy book, first South Asian edition book. He is the editor. And he is a joint editor and section editor for neuroanatomy and genetics. He is the editor-in-chief of National Journal of Clinical Anatomy, which is a approved, which is a official journal of SOCA. And within a short period, he got this journal, which is indexed under the Scopus, which is his recent success. And as a learner, he learned his UG in Sri Krishna Medical College and Hospital. He completed his PG in JIPMER. He did his FAMER in Manipal, and he completed his MBA. And now he is pursuing his PhD in cytogenetics. As a designation, he is a designate as an additional professor in anatomy. He also has a crown as an assistant control of examination, assistant dean academics, and ex-sub-dean academics in AIIMS Rishikesh. And he is also worked in North America as a ex-course director and head, School of Medicine, Spark Health Science University. And he is none other than Dr. Kumar Satish Ravi. I welcome you, sir, to deliver this topic, Research in Anatomy, Challenges and Solution amid the COVID-19 pandemic. Welcome you, sir.
Thank you.
Thank
so
you
much.
for the opportunity.
Thank you so much, ma'am. Please allow me to share the screen.
Yes. So now you can share your slides.
Yes.
The award.
Am I audible, sir?
You're loud and clear, sir.
Okay. So good afternoon, one and all. Honorable chief guest, eminent speakers, dignitaries, respected seniors, and my dear colleagues. First and foremost, I thank the organizers, especially to mention Professor T. Rajan sir for organizing such a wonderful conference and providing me this opportunity to share the platform with eminent resource persons across the world. Indeed, I'm overwhelmed by the wonderful response of the delegates. And today I will be talking on research in anatomy, challenges and solutions amid the COVID-19 pandemic. So today, most of the talks were focused on online teaching, assessment, competency-based medical education, etc. Hence, I've been assigned this topic since research and teaching forms an integral part of an anatomist, you say. As such, being a preclinical subject, you say research in anatomy, or you say has a limited scope and COVID appropriate restrictions, you say, and apart from that, you say these restrictions or has restricted the research opportunities available for an anatomist. So in this session, I would make a humble attempt, not only as an academician, but as an editor-in-chief of the National Journal of Clinical Anatomy, to throw light on those first areas which can be looked upon for better opportunities. Now, when we talk about this research, the very first question which comes to our mind is, what do you mean by research? So research is a careful and detailed study into a specific problem, concern, or you say issue using the scientific method. Now, when we say this research needs well earning knowledge, and you can say that applying it, patients on trials, oriented goals, and no excuses. So all these terminologies, if you see over here, you need to arrange these terms in order to use this weapon very strongly. Now, when we say this, because today we have the delegates from the different branches of medicine, we have the, you say anatomy, biochemistry, and physiology. So they will be discussing in general about the research at first. So let me pose a basic question, that why do we do research, or why do you do research? The main purposes of the research, if we say, is to inform action, gather evidence for theories, you can say, and contribute to developing knowledge in a field of study. Now, when we see this, we humans have learned a lot over the course of over approximately 200,000 years for existence, and most of that knowledge is there in the books, or you say online, which is available freely. And everything we learn helps equip us for future challenges. You never know when a particular nugget of knowledge might prove useful, and it starts with research. So in the present competitive world, you say, conducting research is not just important, but it is imperative. It's a tool for building knowledge, and you say the facilitating learning. The research means to understand issues, and it increases awareness about the subject of the interest, you can say. It further helps us to succeed in the career, whether it is related to the student, or you say the faculty members, be it the academician or the scientist, or you say the researchers. This allows us to disprove lies, you can say, and the research support the truths. It's a means, you can say, to find, gauge, and seize opportunities. And apart from that, you can say that research promotes a passion for, and you can say that it develops the confidence in reading, writing, analyzing, and sharing the valuable information. So in a constructive way, we can say that it provides nourishment and exercise for the mind. Now, apart from that, when we see this research, it is the field we mainly do research for the publications. As an academician, if you say whoever is the faculty in the institutions, they basically means in general, if you say they do research for the publications, because as per the National Medical Commission, you say, or you say even the Institute of National Importance like JIPMER, AIIMS, PGI, they promote the faculty on the basis of the number of publication, the number of citations, you can say, the age factor, age index or I index. So these criteria are there for the promotion of the faculty. So the publication in indexed journals, if you say, is one of the most important criteria for the promotion, either you say the National Medical Commission or even in the INI. So as an editor-in-chief, my sincere advice to any researcher will be is that to publish your ideas or your studies. So you should publish or you will perish. Publish in a high impact journals or you perish, or you keep publishing frequently in the high impact journals and maybe you won't perish. Now, always remember the very first question which comes to our mind, that you may do plenty of paper presentations, but it is a publication that remains as a document. Suppose if I'm delivering a guest lecture today, but the question arises how long it will be remembered. But once you publish your work, it will be stored in the database in your name. And even when you don't exist, even when you will no more be there, your work will always be remembered, because whatever you have contributed is documented and it is stored in the database. So why publish at all? If your research doesn't generate papers, it might just as well not have been done. Even if it is interesting, but it is not published, it is unpublished, it is equivalent to the non-existent, you can say. So you must realize that your objective in research is to formulate and test hypotheses, to draw conclusion from these tests or studies, you say, and to teach these conclusions to others. Your objective must not be merely to collect data. Now, when we narrowed on to anatomy, I said the research in anatomy, when you say the scope is very limited, right? And when we talk about the scopes of research in anatomy, there are various you can say the branches in the anatomy. We have the gross anatomy, in which you could study related to the muscles, the nerves, artery, or you say the neuroanatomical structures. And in osteology, we do study about the bones. And whereas in embryology, we study about the development of life and related topics. And presently, most of the anatomists, what we have observed, that they are more interested towards the cytogenetics, and they are working, they are trying to learn, and they are trying to work in the field of genetics. When we talk about this applied anatomy, we can collaborate with different surgical specialties, like we can collaborate with the surgeons, we say the orthopedicians, we have the gynecologists, neurosurgeons, even with the radiation oncologists, we can collaborate, and so on. So what is the purpose of your study? How you should contribute? So you can add your views to the lacuna existing in understanding the anatomical basis of these diseases. When we talk about this radiology, you are studying anatomy by the non-invasive methods, you can say. Then similarly, you can study the structural anatomy, that is the histology, the molecular or the cell biology. Apart from that, now a trend has developed in the medical education. A lot of people are working in the medical education, even the comparative anatomy, or you say the anthropometry. Now, this is the graph you can see over here, right? This is a rough graph showing the manuscripts submitted to the National Journal of Clinical Anatomy sometime before. Over here in this graph, when you see over here, this is showing the manuscript submitted in the branch of, you say, the clinical anatomy or the gross anatomy over here. Then we have the osteology related to the bones. Then we have the medical education, histology. Then we have, you say, this anthropometry. And then apart from that, radiology and the embryology. So what I wanted to say over here, or you can say why I put this slide over here, that you can appreciate one thing, that most of the manuscripts were studies done using cadavers or the bones. Over here, you can see this, the major portion of the manuscripts, what has been received at the National Journal of Clinical Anatomy was related to the gross anatomy either, or then the osteology. So this scenario is not different concerning the, you say, the postgraduate dissertation or the thesis, what they pursue in India, you can say. So directly or indirectly, significant number of research studies in anatomy revolve around, you say, the cadavers, the bones, or the tissues from the cadaver. So I think by this rough assessment, now it would have been very clear that why this challenge has become more critical during this pandemic. Now, when we talk about this COVID-19, as the previous speakers have said, that the world is witnessing one of the dreadful diseases of this era, you can say, that now we have termed it as the COVID era, COVID-19 era, and because of its devastating effects, you can say. So high transmission rate, which spreads from person to person via droplets, you can say, or indifferent behavior of the virus, lack of fixed regimen of the treatment, you can say, had compelled us to stay at home and experience the complete lockdown. So obviously there was a paucity of, you can say, the academic activities due to the online teaching. And apart from that, even the faculty members from the preclinical subjects, they were assigned the duties related to the COVID, or you can say in the COVID ward. Now, so when we see over here, we can do the collaborative studies, right? Related to the patients, or you say the hospital related studies. But what has happened that when you see this study was conducted by me, right? Related to the patients, those who were exposed to the radiation. So we were trying to study the radiation induced nuclear changes in oral carcinoma patients. But because of this COVID-19, you can say the collaborative studies are quite impossible these days because of the, you say, the stringent regulations are there, or even the recruiting patients for studies, particularly in anatomy, is definitely quite difficult. And not just for, you say, the fear of infection, but if we need to recruit this patient, that also have to follow the COVID-19 protocol, and which another adds to the work burden, and even you say that it also adds to the expenses as well. And this is one of, you can say, the work which were in which the oral or the oropharyngeal carcinoma patients were involved to study this micronuclei response to the radiation-induced changes, you can say. But for the past 1.5 years, the similar studies we were not able to do in the department because of the, you say, the patients in the cancer clinics are not reporting because of the COVID-19, and it was not that safe also to take the scrapings from the buccal mucosa of the, you say, from the patients. So these were the hurdles. Apart from that, if you see in many medical colleges, you say, or you say that when the guidelines from the Ministry of Health, Government of India came that you should avoid this embalming, the most of the medical colleges of the country have suspended this body donation programs and are not accepting the cadavers. So even we need to aware about that. So you can see even the newspapers, it has they have published that thanks to the pandemic, the cadaver donations come to stand still. When you see this over here, right, in 2017, the 60 donations were there in Mumbai, whereas when you see in the 2020, it was almost 24 cadavers were received. And since after March, you can say 2020, this COVID-19 was 19 was there, or the this COVID era started. So that period, this body donation was completely stopped. Now, as I said, that embalming of the COVID-19 affected cadavers was also not advised because the ministry gave the guidelines that you should completely avoid this embalming because of the spread of the infections. So there are still so many dilemmas regarding the same because some of the institutions, from institutions we keep on getting the calls that whether you people are doing embalming or not, and what are the precautions we should take during the embalming. Suppose if the administrations, they ask you to perform embalming. So there are dilemmas are there, and in some of the colleges, embalmings are being performed in these days, you can say. But if you see over here that because of this, we are not performing the embalming or the body donation, if not immediately, what will happen that over a while, this can lead to an acute shortage of cadavers. not only for teaching, but even for the research purposes, because as I said, the data we have given that most of the research in the Department of Anatomy revolves around the cadavers or the bones or the tissues. So definitely because of the scarcity of the cadavers in the Department of Anatomy in various medical colleges, this will affect not only teaching, but it will also affect the research of the anatomist. Now, to some extent, if you say the scarcity can be overcome by teaching, you say by just the previous speaker were discussing that by virtual method or the virtual dissections, you can teach, and already available specimens are there, models are there, right? Artificial cadavers are there. With the help of those virtual dissected tables, you can teach. But what about the research? So there is a dire need to have other possible sources to continue the academic, or you say the research work in the different institutions. So this is the right, you say, the critical thinking, and to explore the other areas which can be explored for research and you can say the publication. So as I said, that necessity is the mother of invention, because earlier when we used to teach our students only by means of the cadaveric dissection. But as there was a scarcity of the cadavers, and during this pandemic, you can say, we have started this online teaching. That was the invention, a sort of, you can say. And then accordingly, we have started using the virtual dissector. So accordingly, even in the research, because when there will be a scarcity of the cadavers, there will be a scarcity of the bones or the structures, the tissues, you can say, definitely there will be some invention, and accordingly, we will change our way of thinking or the procedure of or the methodology to do the research. Now, when we see over here in this diagram, right, the animal models were existing. We used to do a lot of research work related to the animals when this animal house was mandatory in all the institutions. But because of the, you say, these animal models have been used to address a variety of scientific questions, right? From, you can say, the basic science to the development and assessment of novel vaccines, you can say, or the therapies, remarkable anatomical, or you can say the physiological similarities between humans and the animals, particularly you can say the mammals. And these have promoted researchers to investigate a large range of structures and mechanisms. So the main hindrance is, again, as I said, the stringent laws are there with respect to the animal handling, and apart from that, you can say the funding. But if you have an animal house in those institutions where it is already existing, right, and easy access of procuring experimental animals, the best area to proceed, you can work on that, and then you can do the research and you can publish your studies. Research, you can say, on relevant and the carefully designed, the well-characterized and controlled animal models will remain, you say, for a long time, an essential step for the fundamental discovery. Either you say for testing hypothesis at the organism level, and even for the validation of the human data. So animal models, I would suggest that it must be constantly improved to be more reliable and informative. Now, if you see in this study was recently published in the National Journal of Clinical Anatomy. Why I put this slide, that if not the whole animal, if we can procure or sacrifice, try doing a study on particular organs. So see over here in this study, the methodology, this observational descriptive type of the study in some of the medical college of Kota from December 2019 to January 2021, they have done. After seeking proper ethical committee permission is required, whether it is human or the animal. So what I wanted to say over here, that apart from this human, they have got the 70 goat kidneys, right? So what I wanted to say, that if you are not able to get or procure the whole animal, you can procure, you can get some of the organs from the slaughterhouse, and with mandatory institutional ethical committee, you can work on the various studies, you can plan, you can formulate some of the studies based on that. Now, next is the comparative anatomy. Over here in this, you can see over here that the cerebellum has uniform cellular structure. This article was published by Sultan et al. And in this, what they have done, that as I was saying, that another area which are least explored by the anatomist, you can say, especially when you talk about the India, is the comparative anatomy. So I have quoted this example for this meaningful insight, which can be added by studying the microanatomy or physiology in accordance with the applied aspects or the clinical anatomy, you can say. Apart from that, if you see over here, recently this yoga and meditation, these are the trendy topics nowadays, not only in India, but even you can say the other part of the world, you can say in the abroad. The anatomists can consider taking studies starting from the effect of yoga on various systems of the body to studying the effects of the same on various physiological activities. We are promoting this yoga and meditation since I'm based from Rishikesh, and Rishikesh is the capital of yoga, you can say, in India. And even presently, the government of India, you say, is promoting the research on the yoga, and they are funding a lot of funds, spending so much money on yoga and related studies. So there are various grant proposals called for yoga related studies. So you can take the benefit of these funding agencies by the government of India, and you can plan your project, your study related to the yoga and meditation. This will definitely help working during this pandemic period. Now, when you see this clinical anatomy, this is the well-known Journal of Anatomy. This is a Journal of American Association of Clinical Anatomy. In this journal, you can see over here, they have Ivanga et al. They have published an article related to the mandibular canal versus inferior alveolar canal. It's a Delphi study. So why I have put this study over here, that when you collaborate with the clinicians, right, who are contributing or for the better understanding, you can say, of the disease process or the treatment options which are available or which are followed since ages, you can say. But when whole medical faculty is diverted towards the management of COVID-19, proceeding means collaborating with the different clinicians during this period will definitely be very difficult. So what these anatomists, they have done, right, they have done a collaborative study, but what the authors they have done, they have prepared a questionnaire method, and these responses were gathered through email from the different parts of the world. And these responses were collected by clinicians of different branch and presented in a national way. So what they did, they performed a Delphi study to evaluate the current understanding and use of the terminology in different geographical regions and areas of expertise, and to determine the appropriate terminology for this bony canal. A Delphi panel was formed and questions were sent and answered via email, and accordingly they have published their work. So this is another idea, performing this Delphi study and doing some of the research works and contributing to the medical fraternity. Now, when we see, because I said that nowadays so many anatomists, or you say the faculty from the basic medical sciences, they are more interested towards the medical education, right? And currently, as per the National Medical Commission, we have been directed to follow the competency-based medical education. There are ample opportunities in the field of medical education. You can say starting from the foundation course, which we do when the first year students join, or you can say the flipped classroom, the assessment, you can say. So by developing a robust methodology, and you can say the critical analysis and the presentation of results, these are must, and you can plan, the studies can be planned accordingly, throwing light on existing method and other innovative methods, you can say, used in teaching and learning. Here, this Dr. Ghulam Bhatt, what they did, that they have a recent advance in medical education is in correlation with the advances in the information technology, and those computer-based learning is being increasingly employed. So the objective of his study was to design and evaluate an e-learning module in anatomy and to assess the perceptions of students and faculty about this e-learning module. So they developed one e-learning module. So accordingly, you can plan and you can invent and you can develop some different modules. Accordingly, you can work and then you can publish your research work. Now, when you see over here, during this pandemic, there was surge in the studies related to the online teaching, you say, and apart from that, assessment, the students, teachers' perspective, and most of these studies were done using the Google Forms, you say, or via the email responses. So always be alert and ensure who are the learner and the newer technology like creating and analyzing these Google Forms and administrating the online, this multiple choice questions, or you say the clinical vignettes, etc. So this was another article published in this National Journal of Clinical Anatomy. They have a study related to the learning human anatomy amid COVID-19 pandemic. And they have, because most of the initial articles, what we have seen, they have published about from the faculty's perspectives. And this was one of the article they have worked on the students' perspective. And accordingly, what they did, that students emailed in anatomy courses during this spring 2020 semester and were asked to fill a questionnaire within 6 weeks of the end of the online classes. And the questionnaire included questions about the students' perceptions and the preferences about learning anatomy during this period. So these are the different perspectives you can think of, and accordingly you can design your research work. Now, we should not be restricted to the medical education, but such online surveys can be done on other aspects, like you say, the awareness regarding this body donation, or even the anatomy museum, you can say. Here in this study, they have done to assess the knowledge, attitude, and the practice of organ donation among pharmacy students. What they did, that a web-based cross-sectional study of students pursuing different pharmacy courses was conducted, and they especially designed questionnaire which was used to survey the students. So what I wanted to say over here, that even we anatomists can conduct such kind of survey regarding this body donation or anatomy museum. So you have to think accordingly. You should always think out of the box during this pandemic, so that you can continue contributing some of the research in the medical field. Now, when we see over here that you can collaborate with other professionals as well and use, because just now the previous speaker, they were talking about the technology. So we can collaborate with the other professionals as well, and we can use the different technology in analyzing the various things, like we say you say the lip prints, or you can say even the dermatographics, etc. And that will add more accuracy to your results, and it will add weightage to your studies. So what I wanted to say, that this COVID pandemic 19 is still existing and it will continue. And with these recurring waves with different degrees of severity, you say, at different parts of the world. So in spite of many restrictions and stringent regulations, you can say there are pretty good opportunities for research in anatomy during this ongoing pandemic. And we don't know the behavior of the, you say, the different behaviors of these ever mutating coronavirus. So this session is just to make aware of other means of studies, which mainly deals with areas with the, you say, the cadaver uses. So with the given examples, one may feel that every kind of studies can be done or have already been done, but it always depends on how you understand such studies and pick up those limitations from those studies and add your ideas. And as I said, that always try to think out of the box, right? So this is, in the end, I would like to say that our minds can atrophy, just like the muscles gets atrophied. So similarly, our minds also can get atrophy like our muscles, and conducting research, whether it is formal or casual, is a great, and you can say it is a great way to keep our brains healthy and active. So the more you engage your analytical mind, the better equipped, or you say you will be evaluating the information, you will be making the decisions, and you will try to solve the problems, and you will engage in the you say the meaningful discussions. So I hope I have tried my best to do the justice with this, and hope it will ignite the young minds or your minds to thirst areas of researchers other than the traditional modes what we were doing related to the cadavers or the bones or the tissues. Thank you. Thank you so much for your patience hearing. Thanks a lot.
Thank you, sir. Over to the chairperson.
Thank you, Dr. Kumar Satish Ravi, for your illustrious lecture. I would like to congratulate the organizing team of Arupadi Vedu Medical College for arranging such a wonderful international conference. And personally, I would like to thank Dr. Professor Rajan and Dr. Ilangadir for having given me this opportunity to be the chairperson for your talk. You have rightly pointed out the importance of research, importance of publication, the problems faced by the PGs, researchers during COVID pandemic, and also you gave the solutions very correctly. As you pointed out, necessity is the mother of invention. So when we travel, when we come across some block, our mind thinks what is the alternative path to overcome the traffic jam and reach our destination. The same way, we have to find out some methodology. We cannot stop the research. It has to go on. And we also faced in our department how to overcome this difficulty. The main challenge was to get cadavers during this pandemic situation. And especially for clinical students, it was a tough challenge to get patients because all the OPDs and inpatient, the wards were closed. So they were left with no choice. So we changed the studies into retrospective studies. I myself faced this problem. I would like to share my experience with you. When I was in JIPMER, I had two candidates and I know that this will be a difficult situation. So I wanted to collaborate with the radiology department. I gave angiographic studies for two of my PGs, and they are now about to complete already. They have completed. And like this, we can think of some alternative possibilities, as you said, animal studies, and then collaboration with the other departments, collaborating with other specialties. All these are the alternative things. So, I don't have any questions because you explained so clearly, very well. There is no questions from my side, but I would like to invite questions from Dr. Shantini Arulselvi. If she has any questions, she can ask. And I also open the discussion to the participants. If they have any questions, they can ask.
Thank you, sir. I can see one
Thank
question.
you, sir. We have one question in the chat box, sir.
Yes, sir.
When we are with the midst of COVID pandemic, can we start accepting the cadaver donation?
Yes, sir. I've seen that question from Dr. Rashmi. See, the guidelines from the ministry was that we cannot perform the embalming, but the new guidelines has not come. But what we are doing in our department, we have started taking the body because as whatever the body is coming to our department, first we ask them to go for the COVID test. If the COVID test is negative, then we perform this embalming, and we have started taking the body. But it is up to the administration of your institute, right? That if they allow, you can go for the body donation. But if they don't allow, you cannot take this. So as per our administration, as per the institute, All India Institute of Medical Sciences, Rishikesh, we say we have started taking the body donation. I hope I have answered your queries, ma'am.
In JIPMER also, we had such cases because if it is a non-COVID one, very clearly it is due to some medical condition, somebody dying in ICU, and then we take the test one week because we know the person is going to die. So the COVID test was done. We had such some 2 or 3 incidents like that in JIPMER. we repeated the test just before death also, and then after death also we waited. We took the test only when it was negative. We accepted the body.
Right.
So this is the situation. We have to judicially, we have to analyze each and every case. We cannot generalize that one. It all depends upon the situation. What is the condition by which they are dying, and if we know very clearly that it is a non-COVID death, I don't think, and if your institution agrees, there is no harm in accepting the body, because otherwise there won't be any bodies for teaching purpose as well as for research. This is my view.
Exactly, sir. Because now, because of this COVID-19 only, in all the medical colleges, whoever is doing post-graduation, their sample size have been reduced because of this COVID-19 pandemic only.
Yes,
and
sir. Yes, sir. Yes.
Most of the colleges now, when we are going for the examination, we have seen that the number of cadavers what they are having is very limited. You can say 2 or 6 or something like that. So if situation permits, we can start the body donation program. Thank you, ma'am.
Thank you, sir.
Wonderful presentation. You have
Thank you, ma'am.
completed the presentation within the stipulated time, sir, and you have widely opened our eyes. The research field in anatomy is very wide, which is like a ocean. Okay, we have to swim which part we want to swim. Ocean is a big, it has a different names. So which ocean you have to choose. If you choose a medical education, we can go with the medical education. If you want to take a clinical anatomy, we can go with that. So you have given very nice ideologies and publication, how much important that recent times we are all came to know by NMC guidelines. For each and every step, if you want to cross, you have to publish at least a paper, whether it is a pandemic period or non-pandemic period. It doesn't matter whether situation demands, you have to publish. So it's up, depends upon the individual, how they are taking it up. And you have nicely given the ideologies. I think the young minds, they would have been picked up. Even we also publishing each and every year, we have to publish 2 papers. Until otherwise we prove ourselves that we are alive, that no one think that we are alive. So we have to prove with that how our knowledge, we are updating ourselves. For that, the publication is needed. It's a wonderful presentation, sir.
Thank
Very
you,
good.
ma'am. Thank you, ma'am.
Thank you, sir. Thank you, ma'am, for the wonderful presentation. And it's time to honor our chairperson and the speaker for today's talk. I take this opportunity to thank our speaker for the second scientific talk today, Dr. Kumar Satish Ravi, sir.
Thank you so much.
Thank you, sir.
Thank you.
At this juncture, I would also like to thank our chairperson for the second scientific talk, Dr. K. Shantini Arul Selvi, madam. Thank you, ma'am. I also thank our second chairperson for the talk, Dr. M. Sivakumar, sir. Thank you, sir.
Thank you very much, sir. Thank you very much.
Thank you, sir. Thank you.
Regarding research funding, I think Dr. Krishna Veni madam has asked. Yeah, I'll please email me, ma'am. I'll email to you regarding the research funding from where we are getting, or whenever they declare about some of the research proposals, I'll try to email you, ma'am. Thank you.
Thank you, sir. Now we have come to the roof of today's scientific talk, our third topic for today. We have with us our presenter. We will be briefing on the telomere, genomic integrity in DNA, dam aging under science, technology, society approach in teaching aging. This is the topic for today's talk, which will be presented by Dr. M. Prakash Hande sir. To chair this session, we have with us our first chairperson, Dr. Manisha B. Sinha. Madam is a professor, additional professor in the Department of Anatomy in All India Institute of Medical Sciences, Raipur. Madam has successfully completed her MBBS and MD degree. Adding to her credit, Madam has been a resource faculty in first online course on medical education technology, AIMS Raipur. Madam has been a member of National Academy of Medical Sciences, has been IMA National President, has received the Appreciation Award for Women for Best Social Activity for the year 2020, has received the Best Editor Award by National Journal of Clinical Anatomy and Physiology in 2020. Madam has been a part of Indian Journal of Clinical Anatomy and Physiology, Indian Journal of Anatomy, Indian Journal of Genetics and Molecular Research, Journal of Clinical and Diagnostic Research, International Journal of Healthcare and Biomedical Research, Indian Journal of Genetics and Molecular Research. She has contributed to more than 50 reputed articles in the reputed journals, both national and international journals. We welcome you, ma'am. Our second chairperson for today's talk, we have with us Dr. Vidya. Madam is a professor in the Department of Anatomy, JSS Medical College, Mysore. Madam has successfully completed her MBBS, MD, and PhD degree. Adding to her credit, she has secured the Gold Medal Award for Best Paper in Clinical Anatomy by Karnataka Chapter of Anatomist. She has received the YT Tathachari Endowment Prize for Best Research Product by Brahmara Trust, Young Scientist Award for Research Contribution by WIFRA International Organization, has been an Outstanding Woman Scientist Award in Anatomy for Research Contribution, Woman Researcher Award by IOSRD organization in 2018, has received the Best Paper Award at 21st State Level Conference held in 2019, has facilitated the Women Achiever on Women's Day on March 8, 2021, has received the Best Teacher Award by Global Teaching Excellence in July 2021, has received the Best Paper Award in Recent Advances in National AVICON Conference held in July 2021, has facilitated a COVID Warrior by Vijayanagar Resident Association, has held up the position of Vice President of Karnataka Chapter of Anatomists, has been a part of the Internal Compliance Committee, Executive Committee member of Society of Clinical Anatomy as a member secretary. Adding, she has also published more than 40 research publications in peer-reviewed journals and has secured the Gold Medal Award for maximum number of publications during the year 2015 and 16. We welcome you, ma'am, to chair the session today. Over to the chairperson to introduce our speaker today.
Very good morning, everyone. Thank you. Thank you, organizers, for giving me opportunity to be the part of this this conference, this mega event organized by AVMC. I wish you for grand success of this conference. Our speakers of this session is Dr. M. Prakash Hande. He's an associate professor at Department of Physiology, Young Lu Lin School of Medicine, NUS, and he is also the Assistant Dean Safety and Research Facilities Management there. He has published more than 160 peer-reviewed research articles with thousands of citations in international journals such as Nature Genetics, Cell Science, Genes and Development, and his research interests are telomeres and telomerase in aging and cancer, experimental cancers, therapeutics, and biomarkers of the radiation exposure. Dr. Hande is one of the pioneers who has identified the role of DNA repair factors in telomere regulation in mammalian systems, and is an expert in radiation biodosimetry. He teaches cancer biology and aging. He holds adjunct professor appointments at Vellore Institute of Technology and Mangalore University, and he is a visiting faculty at KIT University, Bhubaneswar. He is a visiting scientist at the National Institute of Radiological Sciences, Chimba, Japan. He is the founding editor-in-chief of Genome Integrity, an online journal. He is an associate editor of Frontiers in Genetics, as well as the editorial board member of Mutation Research, Genetic Toxicology, and Environmental Mutagenesis. He was also a consultant to the Division of Human Health, International Atomic Energy Agency, Vienna, Austria in 2015-16 during his sabbatical leave from NUS. He is currently an expert member of work group of biological mechanisms influencing health effects from low dose radiation exposure with the United Nations Scientific Committee on the effect of atomic radiation. He is a member of Committee 1, International Commission on Radiation Protection from July of this year. So he is well-known personality. Over to you, sir. Dr. Hande, over to you.
Okay. Good morning. Thank you very much for the kind introduction. At the outset, I would like to thank the organizers, especially Dr. Rajan, for inviting me to give a presentation here on a topic which is very dear to me. If you allow me to share my presentation.
Sir. You can share your screen, sir.
Thank you. Okay, I hope you all can see the slide.
Yes, sir.
In the slideshow mode. Okay, so today this presentation is slightly, deviating from the previous two speakers. I may not touch about the COVID-19 situation as such, but in the second part, I might explain some of the changes we made in the teaching for life sciences and aging. As you see here in the title, I put up both basic science, and then I would like to go into the topic of teaching aging with the science, technology, society, or integrated approach to teach aging to life sciences or any type of students. So to begin with, I would like to highlight that the fact here. Sorry, let me go back. Okay, so we all know that aging is a factor which is causing the humankind to age. There are several theories which explain the aging phenomenon, program theory and stochastic theories. In program theory, we have program senescence, hormonal theory of aging, immunological theory of aging, and telomere theory of aging. Whereas the probabilistic nature of aging would be caused by metabolic rate, glycation, somatic mutation, wear and tear theory of aging, and also oxygen-free radicals. So I'm combining the two sets of theories here, programmed, where telomere shortening, and then the oxidative stress theory of aging. Okay. So to start with, I will explain what are telomeres. Telomeres are the telomeres cap the chromosome ends at either ends of the chromosome. On the image shown here, on the left-hand side, we have human chromosomes, and on the right-hand side, we have mouse chromosomes. Both chromosome spreads are stained by telomere-specific probe. As you can see, the telomeres at the ends of the chromosomes. So this method is called fluorescence in situ hybridization, where we can visualize telomeres on the chromosome, or on the metaphase spreads. So just to define telomeres, telos meros, or end part, and it was first discovered by Hermann Müller back in the 1930s, where he published a paper that broken chromosomes or chromosomes with broken ends tend to fuse with each other. Concurrently, Barbara McIntosh published another paper that chromosome ends with telomeres do not fuse. Okay, so all in all, both these papers highlight the importance of telomeres, as you can see in the images shown here. So 2 images of mouse chromosomes, and then you have the human chromosomes as well. Eventually, both these investigators were acknowledged for their discovery by giving them Nobel Prize, one for Müller in 1946, whereas McIntosh had to wait until 1983 to receive her Nobel Prize component. So what are telomeres made up of? We have a mammalian telomere complex, which is made up of essential RNA component. And then we have catalytic subunits, telomere reverse transcriptase genes, and then associated factors, which we call as sheltering complex. Okay, so in 1998, it was found that the ends of chromosomes actually tend to make it loop-like structure, what we call displacement loop or telomeric loop. So at the boundaries of these loops, all the associated factors, as you can see here, on top of this, protection of telomere 1, telomere repeat binding factor 1, and additional factors which essentially protect the chromosomal ends from any degradation or spontaneous reactions. I'm sure many of you are aware of the telomere theory of aging. It generally says that telomeres shorten during aging. This was first proposed back in the 1960s, theoretically by Alexei Olovnikov and James Watson. However, the biophysical hypotheses were first provided with the biological proof in the early 90s, where Harley et al. Found that telomeres are short in lymphocytes with people suffering from cancer, or the cancer cells have shorter telomeres compared to their normal somatic cells. Essentially, the telomere hypothesis of cell aging and immortalization describes us that when normal somatic cells cultured in the lab, they divide and tend to lose telomeres every time they divide. This telomeric loss or shortening is due to an inherent mechanism called end replication problem. Therefore, somatic cells, if you put them in culture, for example, the skin fibroblasts taken from our skin, if you put them in culture, they have finite lifespan. They can't grow indefinitely. They would start to lose telomeres constantly with every cell division, and then they reach a stage called mortality 1. This phenomenon was first observed by Leonard Hayflick back in 1961. So therefore, the stage at which it stops is called as mortality 1. However, some cells are physiologically active and they still start dividing and losing further telomeres. And finally, they enter a stage called M2 or mortality 2. This is the end of the journey for the somatic cells. Beyond M2, most of our somatic cells will not divide. They will die of DNA damage checkpoint and apoptosis. And essentially, all these somatic cells lack the enzyme telomerase. Okay. However, on the top panel, you have germline cells, which are telomerase positive. The germline cells do not show any telomere shortening, even if you grow them. So they are permanently maintaining their telomeres because of the presence of telomerase. So essentially in humans, when we grow, when we develop, embryonic tissues and cells express the enzyme telomerase because you need cell proliferation. Once the organs are formed, cells are differentiated, telomerase is suppressed. So therefore, in the adults, somatic cells do not express telomerase. Okay. Only the proliferative organs express the enzyme telomerase, such as germ cells, bone marrow cells, stem cells, and intestinal epithelial cells. These cells do not show telomere shortening, and they divide indefinitely, and they are highly proliferative in nature. So all other organs and tissues do not express telomerase, and they have a finite lifespan. Okay. However, cancer cells express high amount of telomerase. Okay, so they are also considered as immortal. The observation that telomerase is important for telomere maintenance and also in addition to proliferation was first identified by Elizabeth Blackburn, and Carol Greider was her PhD student. They discovered the enzyme telomerase in collaboration with Jack Szostak. And these people received Nobel Prize in 2009 for the discovery of how chromosomes are protected by telomeres and the enzyme telomerase. And this is the third Nobel Prize which went to the field of telomeres and telomerase. I had an opportunity to collaborate with Carol Greider before she received her Nobel Prize back in 1997, where I characterized the phenotype of telomerase knockout mice, which were generated by Maria Blasco, who was a postdoc of Carol Greider. And the image, metaphase chromosome image I prepared was used as a cover page in Cell. In this study, what we have done is we knocked out telomerase and analyzed telomerase role in mice. So unlike humans, mice express telomerase in all organs and tissues throughout life. So this is complete opposite of human situation. So therefore, in mice, when you knock out telomerase, the cells show shortening of telomeres in vivo. Okay, so that we published in Cell, as I mentioned. Mouse embryonic fibroblasts start losing telomeres every time they procreate. This is only in telomerase knockout mice, whereas telomerase positive mice do not show any telomere shortening in different generations. Finally, at the 6th generation, telomerase knockout mouse becomes infertile due to the accumulation of chromosomal alterations such as Robertsonian fusions. So these fusions were generated because of the loss of telomeres at one of the ends here. So as you can see here, this image, many ends either lack telomeres or shortened telomeres. So when the P arm of the chromosomes completely loses telomeres, they tend to fuse with each other. So when in vivo, if the mice have Robertsonian-like configurations, they will become infertile. Okay, so they cannot produce offsprings anymore. And in addition, telomerase knockout mice displayed accelerated aging as well. I'll show you a couple of images of our continued work on telomeres. We took out these cells, mouse embryonic fibroblasts, and put them in culture to see whether these cells show any type of senescent phenotype as we see in human fibroblasts. Unfortunately, telomerase knockout mouse cells did not show any telomere, any senescence. However, they did show telomere shortening. However, after prolonged cultures in the lab, we were able to make we were able to see that telomere telomerase negative mouse cells could be grown in the lab for indefinitely. So this is in contrast to the human somatic cells, which also lack telomerase enzyme, which show replicative senescence, as I explained in the theory I proposed earlier. Okay, so this is one of the contrasting observations. And in another study where mouse embryonic stem cells were knocked out for telomerase. Essentially, embryonic stem cells are permanently telomerase positive, and they are permanently immortal, and they divide indefinitely without losing telomeres. Once we knock out telomerase in embryonic stem cells, as you see here, as we grow them, this is about 100 population doubling or 100 divisions in culture. We started to see fusions, as we see here in vivo in telomerase knockout mouse. And as we grow further, these type of fusions accumulated in the cell type, and ultimately it has changed its karyotype completely from an acrocentric or telocentric to a multicentric chromosome. However, these cells did not undergo senescence or death. They are still, we could grow them even beyond 600 times in the cultures, whereas telomerase positive mouse embryonic stem cells could be grown forever without losing telomeres. So for these two observations, we realized that in mice, which the mouse cells which lack telomerase showed a different scenario in culture as we observed in the human somatic cells, even though both are telomerase negative. Therefore, we reasoned that in mice, at least in particular in these cells, there may be another mechanism which may maintain telomeres. So then we went on to look at the telomere role for other factors in maintaining telomeres. So that's how when we bumped on DNA damage, because whenever the cells start to lose telomeres, the cells may sense it as DNA damage. And I highlighted this in one of the proposed models where when somatic cells, they lose telomeres, and then at the end, they would undergo crisis and senescence. During that period, the DNA damage checkpoints are activated. So that made us to think that if the telomeres are getting shorter and shorter, this may sense as DNA damage. So therefore, we hypothesize that the repair factors or the DNA repair factors may be involved in telomere maintenance at least in mice. So therefore, we went on to look at a variety of DNA repair factors in the regulation of telomere length. I'm not going to go into detail about DNA damage process itself. We have 4 different important mechanisms of repairing the DNA damage. Each repair event, base excision, nucleotide excision, mismatched or homologous, they are activated depending on the damage incurred on the cells and depending on the damaging agent which attacks our DNA. Okay, so this is not a fundamental lecture for DNA damage. However, please bear in mind that we try to look at the roles of DNA repair factors in telomere maintenance mechanism. So if we embark on a massive investigation in collaboration with several groups around the world back in the 90s, and we identified roles for DNA repair factors in maintaining telomeres by looking at the repair factors one by one. So the first one is poly-ADP ribopolymerase, which is a DNA break sensing molecule, and then all the factors involved in non-homologous end joining, such as DNA PKCS, Cu70, Cu80, etc. So most of these DNA repair factors, including BRCA1, in our experiments, in our studies, were found to be involved in telomere maintenance. And essentially, most of these knockout mice for DNA repair factors exhibit accelerated aging, high levels of chromosomal instability and genomic instability, in addition to spontaneous cancers. Okay, so they have multiple pleiotropic effect of lacking DNA repair factors. So I just combine here two different fields in aging. One is telomere theory of aging, and the other one is on DNA damage. So both work together, or both pathways cooperate in genome maintenance mechanism. Another protein we highlighted, or we published back in 2001, that ATM, ataxia-telangiectasia mutated gene. And this gene is very important in DNA repair. We have a human syndrome which is called ataxia-telangiectasia. The patients lack this particular gene, and also they are sensitive to DNA damaging agents. Okay, so we characterized this, and we found that there is a unique telomere defect in these mice. And of course, all these factors, as I mentioned earlier, are involved in aging as well. So this is, summarize the part on DNA damage and DNA repair. So what we have seen in the last 10, 15 years is that if DNA repair factors are absent in our genome, there will be altered telomere homeostasis, which would lead to abnormal metabolism, which are actually the effects of shortened telomeres. Okay, and the cells which lack DNA repair factors also display heightened genomic instability and chromosomal fusions. And essentially, most of these cells which lack DNA repair factors are highly sensitive to ionizing radiation and or other types of genotoxic or environmental toxic agents. Okay. In few slides, I'm going to show one of our studies on a premature aging syndrome cells. Okay. That is actually, okay, this one I can skip because I have those slides which I skipped are important in understanding oxidative stress, DNA damage, and telomere instability. So the study I'm going to explain here in a couple of slides is the role of one of the repair factors that is called cocaine syndrome B, which belongs to nucleotide excision repair pathway. CSB is suggested to recognize and display stalled RNA polymerase, recruit other NER factors for subsequent steps in the repair process. Individuals lacking cocaine syndrome proteins display a syndrome called cocaine syndrome. The fundamental symptoms or characteristics of these patients are they are small, dwarfism, dysmyelination, and they show premature aging. And this is a clear indication that DNA damage factors are important in maintaining genomic stability. If individuals lack repair factors, they may exhibit premature aging syndromes. That means they die early in life. On the right-hand side, you have a photograph of a 12-year-old girl with cocaine syndrome, which has characteristics of senile individual or a 70-year-old or even 80-year-old. Okay, so essentially these patients suffer from DNA repair. So therefore, whenever they are exposed to any type of damaging agent, including sunlight or UV light, they will not have any proteins to repair. So in the lab, what we did was we obtained these cells from these patients. We can buy from cell repositories, and we exposed them different doses of H2O2, which produces oxidative stress in the cells. Okay. And we see here oxidative stress in these cells display decreased sensitivity, induced death, and they show early appearance of senescence markers. Senescence markers are used here as a senescence associated beta galactose staining. So the senescence phenotype is early in H2O2 or oxygen treated cells of CS cocaine syndrome. And we followed that up with several assays for DNA damage, micronuclei, and essentially we show that heightened DNA damage and chromosome instability in these cells, and senescent characteristics by telomere shortening, and a variety of genes are differentially expressed in this particular syndrome patient. So it's one example how DNA damage defect in a patient. And these cells are highly sensitive to oxidative stress, and they display accelerated senescence under normal conditions, as well as when you treat them with oxidative stress agents. So in conclusion, lack of function of nucleotide excision factors seems to increase susceptibility of oxidative stress-induced genotoxicity while retaining cell viability. So which we believe contributes to accelerated aging and cancer. So far I highlighted the fact that we have telomere shortening under normal conditions, which would lead to senescence, apoptosis, and aging. At the same time, if our cells are exposed to reactive oxygen species, you will have oxidative DNA damage, and that may lead to telomere shortening as well, leading to further cascade of events. So you have spontaneous telomere shortening. Sometimes this can be exaggerated by oxidative stress. In addition, if the cells are defective in DNA damage repair, they may show accelerated shortening and accelerated aging. So this is the connection between telomere genomic integrity and then aging per se. Okay. So in essence, what I have shown you here, telomere length decreases as we age or in cells which are aging. At the same time, you have accumulation of DNA damage and other chromosomal changes. So this is happening in the genome in humans. How do we explain this to students? Okay, so whether the way I explained here would be beneficial, whether they will understand this phenomenon, because aging is a major complex biological process which is associated with gradual decline in physiological functions. And I don't need to give an aging lecture here, but I'll just highlight the fact that aging is also associated with increased incidence of severity and many diseases, including hypertension, diabetes, etc. Okay, so the first part I finished, in the previous slide, where I explained biological basis of aging, especially telomeres and DNA repair, and of course there are few other pathways which can be defective in aging process as well, or dysfunctional in aging. However, how we can use this in education, how we can teach. A UN estimation tells us that between 2015 and 2030, a number of older person that aged 60 years or over in the world is projected to grow by 56%. You see, I explained to you the biological basis of aging. And now, how do we translate these into a societal or into a society and a younger generation to make them understand the things happening in all of us? So aging, you cannot prevent. It's not a disease. Okay. So how do we explain this? And we need to educate younger minds to understand the aging process per se. As we can see here by this analysis, older person will outnumber children by 2030. So entire world will have more elderly people compared to younger generation. So we have to encounter, we have to socially acceptable to aged population or elderly individuals. So therefore I designed, so we can't just explain biology to the students or to the public or younger generation. We have to make them understand how biology functions in our body. Okay, so that's the idea of designing a educational module to make them understand aging as well as societal and clinical aspects of aging. So this here I used a science technology society based approach, which we call as STS or humanities, for example. So in this particular course, I teach them initially biology of aging, as I did in this particular presentation. Initially, I explained about theories of aging and then mechanisms of aging, processes, cancer and aging. I didn't touch upon telomeres and other complications. And then, most of the aspects of aging scientifically. And then in the second part of this course, I start to teach them about epidemiology, demography of aging, and then physical frailty. Okay. Okay. Yeah. Physical frailty and cognitive impairment, and then aging, depression, society, end of life care in Singapore. Because I'm teaching in Singapore, I have to focus on Singapore related issues, aging, intermediate and long-term care in Singapore. And then finally, we will touch upon technology in aging, how we can use technology to help aged population. So one of the professors who works in the hospital with the psychological medicine department, he conducts a lot of intervention studies on aged individuals. So he was one of our guest lecturers. He explained to the students about how he intervenes the dementia patients by asking them to do gardening and then mindfulness therapy, music reminiscence, and other types of interventions to combat with dementia. It's a semester-long course on aging and society, 13 weeks with 4 lectures per week, 2 sessions of 2 hours, 4 hours per week. And I started this particular module in 2017. I offer this to year 4 life science students. Okay, so I make them to understand the societal aspects of aging, not in addition to the biological process of aging. In my class, there will be 62 students per year, and we have lectures as well as tutorials and continual assessments. Students will be divided into groups for tutorials to interact with them more intensely. Continual assessment is of a written examination. This happens during the midterm. Okay, so after 6 weeks of lectures, they will have to sit for an examination as seen here. And then the essential component of this particular course is field trip. Okay, I'll tell you where we go. Mostly we go to Institute of Mental Health, Singapore, where the students will go to a geriatric ward where the dementia patients are housed, okay, in the Institute of Mental Health, and they have to write a small report on that. I will also use documentaries on aging, dementia, and dementia villages exist in the world, etc. So exposing them to more of a societal aspects of aging per se. Finally, they will have to present a research article to the whole class, and that is evaluated. And I also make it compulsory for these students to attend the class, because 10% of the assessment goes to attendance. Okay, otherwise, it doesn't make any sense. So in the first half, I have mostly biological, as I said. In the second half, there are about 7 lectures from guest speakers who are experts in sociology of aging or clinical aspects of aging. I'll skip this, but we set a number of learning objectives for this module, including molecular processes, learn about translational science of aging, compare and contrast process of aging and cancer, critically evaluate societal perception of aging and its impact on society. And they need to assess and evaluate biological, social, and psychological aspects, and essentially to understand the concept of healthy aging and an ageless society. So you can ask me questions later on what is an ageless society. Some of the photographs from the lectures, unfortunately, because of COVID-19, last year we had to go for hybrid lectures since March 2020. This is one example. This particular lecture is even webcasted as well as done live for the students who attend the classes. So there will be lesser students in the class and few are attending online. However, this year it's completely virtual on Zoom. As you see here, we have in a close interactions. I ask usually several questions in the virtual sessions. I have only 2 minutes left. I'll try to finish. As I mentioned, we have several guest speakers. One of them is Dr. Lydia Su. He belonged to, he's an epidemiologist and with Leukemia Society. She explains about feminization of aging, so most women, most older persons are women, therefore we need to take care of them. And then we have another guest speaker, Dr. Chetna Malhotra from Duke NUS. She explains about palliative care. And then we have intermediate and long-term care and demography of aging by Dr. Rahul Malhotra from Duke National University. As I mentioned, we have an expert aging researcher in our medical school, Dr. Prof. Kua E. Hoke. He is the one pioneer in intervention studies in dementia. So he had several clinics which focus on dementia interventions. And we also explain about age-related disorders, conditions, and how we can intervene these situations. Lastly, we introduce a topic called technology aging, how technology can benefit and help the aged population per se. And you see here there are student chats. I also show them some real issues in aging in the population, such as documentary on aging. And these are Singapore cases and how they are monitoring in the age homes. As I said, the field visits are essential component of this particular course, where the students have an opportunity to go to the clinics which are focusing on therapy, art therapy, music reminiscence, and etc. Okay, so essentially the students are allowed to go there with maximum 5 to 10 students can witness such intervention studies. And as I mentioned earlier, we take every year students to Institute of Mental Health, where they visit the geriatric ward, which houses the dementia patients, and then the activities they conduct in that particular ward would be witnessed by our students. There will be virtual assessments. As you can see here, this is Proctor. Our tutors, they conduct tutorials, even using surveys. And then we have student discussions and presentations. Here is one of my co-lecturer, Dr. Karthik, and tutor students. We all discuss intensely about the topic. Let's just, in the last slide, I will show you the student feedback for this module. As you see here, students like this type of approach very much. The integration of societal perspectives. It was really interesting and enlightening to hear from specialists from different fields. Some even say chill and enriching. The guest lectures were very insightful, bring up societal issues about aging, an interesting concept of intertwining both biological and sociological aspects. Loved the field trip to IMH, or Institute of Mental Health, where we go to see something most of us probably would not get to experience otherwise. And some feel that this is an effort for them to understand how and where they can go and work later on. So, and this particular student, he probably started to think more deeply about his future career in the aspect of healthy aging and community health. Okay, so I'm sorry I took 2 minutes extra. Finally, I acknowledge all the past students and staff in my lab who worked on DNA damage and telomere work, and then all the students of life science students who took functional aging module, lecturers, guest speakers, and tutors of the module. And I thank you very much. I'm open to take any questions if you have.
Thank you, sir. First and foremost, I congratulate Dr. Prakash for taking us through a journey of telomeres, genome integrity, and DNA damage repair in aging, which is the most important aspect or in the trend in the present era. So first and foremost, I congratulate the team of Scientific Committee, BMS Con, AVMC, and Dr. Rajan for giving this opportunity. Sir, just can you, brush upon, can you give tips how this DNA damage can be prevented for healthy aging?
Yeah, see, what I highlighted is some of them are spontaneous endogenous damage, which we cannot prevent because every cell has to divide. And during cell metabolism, you have oxidative phosphorylation, so which releases oxidative free radicals. Okay, so therefore, it's not that these damages are not being repaired, but if in a healthy individual, there is a balance between free radical production and then antioxidant mechanisms. Okay, so if there is an imbalance where we have more oxidants and less antioxidant mechanisms, then the damage will be prevalent. So yeah, it can be prevented by maintaining that balance of oxidant production and antioxidant mechanisms. So that's the only way to prevent endogenous damage. However, when we go out, for example, you have exogenous DNA damaging agents. So whatever we consume, the food, that may produce some type of DNA damage. So it is rather difficult to prevent, but to avoid, not prevent. It's difficult to avoid, but it can be prevented by minimizing the exposures.
Is it like minimizing the DNA damage through yoga? Any literature on that?
Yeah, there are plenty of reports available. Intervention mechanisms where you can prevent or produce more antioxidants in the body so that you can combat with the DNA damage which are inherently produced in the genome. Yes.
Okay, sir. Coming to this Science Technology Society, this was a new thing for me as such, and the curriculum was very innovatively framed for the benefit of students. Is there any unique value to the methods of science and technology, sir?
Yeah, I think I'm not sure whether medical colleges in India are having any humanitarian lectures from humanities, for example.
Yes, sir, we do have electives.
Yeah, but I think that is one important aspect, because even if you graduate with a medical degree, you need to, maybe it is important to have some societal aspects. Okay, I give lectures on intermittent fasting and genome health maintenance, for example. I don't think any clinicians advise the patients to prescribe patients to have lifestyle changes, right? Very less, or dietary restriction, right? So this addition of societal approach will help even for medical students, because so that when they become clinicians, when they become practitioners, I think they'll think about the societal aspects of diseases as well as treatments, right?
Thank you,
Yeah.
sir. As you told, we are ageless society.
No, ageless society is Singapore wants to start in that way. Thereby, when if you have a job advertisement, for example, no one should discriminate because of aging. Okay, so that's like ageless society. So different age groups can do certain things, right? So there will not be any discrimination for aged and young or children. So everyone is equal. That's why the concept is ageless society. You shouldn't have age as a barrier for working, as well as the societal functions and how do you live in the society. Okay, so I was highlighting about the dementia village. You can search on internet. You find nice documentaries on dementia village. Dementia village, where only dementia patients live. Okay, there is no discrimination for them. Everyone is demented, but they live happily, hopefully. I mean, that's the idea. They live because there is no discrimination for them, right? Even if they forget to lock their room, it's okay because there is no lock in the room. They can go anywhere, right? So such concepts are like, ageless society is something like that. So you will have people who have equal opportunity irrespective of age. I think, I can discuss about this for
yes, sir. Very true, sir. I think like organizations like NGO and Rotaries, they should collaborate with the medical college for the betterment of the society.
Yeah, and I mean, I request that probably in your, in AVMC medical college, there should be something on STS approach for, disease-based thing. I teach here on a course called Biomedicine and Society. Okay, so you discuss about diagnostic procedures, COVID-19, someone has put a question here, right? How sometimes infectious diseases can lead to stigma, right? So dementia is one stigma. Even infectious diseases, in the early phases, you have a lot of stigma in the society, right? So to prevent such stigma, you need such approach to teach them, to make them understand. Communication and public perception is very, very important. I see that there is a question.
May I ask one question?
Yeah,
So,
sure.
Dr. Vidya, may I ask
Yes,
one
ma'am.
question?
Sure, please.
Just I wanted to know, sir, what method you use for quantitating this DNA telomerase or telomeres? What quantitative method you?
Yeah, so I mean, for telomeres specifically, for example, the conventional method is southern blotting by restriction enzyme method. Now there is a modern technique called qPCR technique, but in our lab, the technique we developed, which is quantitative fluorescence in situ hybridization. So where I showed two images in the first slide, right? So chromosome stained with telomeres. So what we do is we capture the images and measure the fluorescence intensity of telomeres on the chromosomes. So that we developed when I was working in Vancouver, one of my co-worker who is an engineer.
Which one is better, sir? Which one is best one to for
So
measurement
it
of
depends.
this?
It depends. If you are doing a population study, it's very difficult to do the one I use here, quantitative fluorescence in situ hybridization. qPCR probably is the best because you can run hundreds of thousands of sample in one day. And then we shouldn't depend on one technique to understand the biology of telomeres. So if you do qPCR and then you will find some individuals with very short telomeres, say for example, then go to the quantitative fluorescence in situ hybridization, then you will find some other aspects of telomere shortening like genomic instability. Okay, so it depends on the purpose and objective of your study. If you want just telomere length measurement, I think the best is a qPCR method. But if you want to study the mechanisms and implications of telomere shortening, then you need to do cytogenetics, chromosome studies, and probably the age-related markers. Okay, yeah.
Okay, sir. Okay, thanks, sir.
Thank you so much, sir.
Someone asked about COVID subjects. Right? I mean, I'm very much skeptic about the publications on COVID-19 and telomeres, but I'm not very fond of relating everything to telomeres. But somehow, when you do such studies, I'm not very sure it can be a predictive marker, but I don't believe that it is a marker for COVID-19. Okay, because it's a universal disease. No one is prevented from it. It's an infection, right? Okay, I'm sorry for an ambiguous answer, but I don't consider this as a marker for COVID-19.
Thank you, sir.
Yeah.
Thank you very much for elaborately explaining the aging process and the curriculum aspect also.
I hope
congratulate
it
once
touched the
again.
COVID topic of the conference, but some sort.
It was unique, sir. It was
Yeah.
unique. Thank you, Manisha ma'am. And thank you, organizing committee and
Dr.
technical
Vidya.
team.
Yes. Thank you, Dr. Rajan. Thank you, sir.
Thank you, ma'am. Thank you, sir, for the wonderful presentation. So before we have the honorarium, I have a small announcement for the participants. Parallelly, we have started the scientific presentation running on 5 halls. So we have provided the link. Participants can join their hall wherever they are interested in. Thank you. Now we'll get into the honorarium part. So I take this opportunity to thank our speaker today, Dr. M. Prakash Honde, who has elaborately gave a scientific talk on the telomere genetic integrity in DNA. Thank you, sir. I also thank our chairperson for the scientific talk today, Dr. Manisha B. Sinha, madam. Thank you. I also extend my thank to Dr. Vidya, ma'am. Thank you, ma'am, for chairing our scientific talk. Thank you.
Sir, Dr. Rajan here, sir. Thank you so much, sir. Thank you so much, ma'am.
Thank you.
Thanks.
Thank you, sir.
Thank you.
Dear delegates, the session is going to start at 2 o'clock. Parallelly, the scientific presentations, you please join in the respective hall. Thank you all. Sir Pankaj, sir.
Yes, sir.
So we end our the morning session, sir. Thank you so much. So
Okay,
tomorrow
sir.
we'll meet, sir. Tomorrow we'll start at 8:30, sir.
So yes, same time, right?
Okay, sir.
Tomorrow sessions are starting from 9:15, right?
9
Right,
o'clock,
sir?
sir, or 9:15. I did not say any. 8:45. If you are starting, also no issue, sir, because the inauguration is over. Remaining
Yeah.
things under the scientific chairperson and the speaker.
Fine, fine, sir.
It will go like that. So the moderator, you need not bother about to include. They are in the same BMS, Econ, and MC.
Okay. Okay.
Thank you so much, sir. And
Okay,
whatever
ji.
the photographs missed, if it is possible from the recorded video, you can send me, sir.
Sure, sir. Sure.
Okay, thank you, sir.
Okay. Thank you.
You can end the meeting, sir.
Okay, sir. Thank you. Bye.